Start. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on treatment and management of lung cancer archives from 2022. With immense pleasure, I would like to invite Dr. Sajjan Raj Purohit, who is Director, Department of Medical Oncology, BLK Super Specialty Hospital and Max Super Specialty Hospital, Delhi, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you, ma'am. And indeed, it is my pleasure to have this 2 days evening symposium, which will extensively cover all the aspects of lung cancer. And lung cancer, as we know, that has been ever evolving, and last 5 years have been game changing in lung cancer. So we will cover various topics starting from the basics, which include the molecular biology, how things are evolving at the molecular or the bedside, and then we'll go to the bedside, where we'll see how the research is evolving and getting new treatments to us on our bedside. So the first 1 hour of today's symposium will be dedicated to the molecular changes and how the molecular landscape has been evolving over the last 1 year. And then we'll have subsequent sessions on both areas which are targetable and the areas where we feel that there is a scope for newer drugs. So without wasting much time, I like to invite the speakers for the first session, which is sponsored by AstraZeneca. And the first talk will be by Dr. Arun G. Kumar from Bangalore, and he will be speaking on molecular biomarker testing in lung cancer. Dr. Arun, good evening to you, and over to you.
Thank you, Dr. Sajjan. Uh, Thanks for inviting me for this exciting series. And I'll quickly share my screen here. Yeah. Can someone confirm if they're able to see my screen?
Yes, sir.
And I'm audible, right?
We can see.
Yeah.
Yes.
Thank you so much. A very good evening to one and all. I am Arun Kumar. I'm a geneticist. As a therapy area expert, I'm working in Roche. So here I'll be talking about molecular biomarkers in testing in lung cancer. So these are my standard set of disclaimers. And with a very basic, I would start with the molecular landscape, which we know has evolved over time with what was found to be just 2 markers to be relevant in lung cancer to over 30, 40 driver mutations that have been identified in lung cancer, which has terribly changed the therapeutic landscape of lung cancer. Now we have targeted treatments available for a variety of different mutations. And the landscape has changed so much so that even within the same gene, for example, EGFR exon 19 deletion has a different set of drugs compared to exon 20 insertion. But although the gene is the same, the landscape of treatment within the gene has also considerably been different. So the critical aspect of this slide is that you have a variety of different targets available for which we have to have appropriate mechanism of testing these targets. So overall, we know there are 4 major strategies of treatment. You have the targeted therapy, you have the chemotherapy, you have the immunotherapy on one side, and you have the immunochemotherapy. And identifying the appropriate form of therapy totally is dependent on the clinical parameters, and more importantly also on the various molecular biomarkers that should be tested on the patient. So the way I will be going about with this talk is that I'll start with the case and try to see what is the take-home message we can understand from the case and take the discussion forward. So to start with the first case, it was a typical 56-year-old female who had a non-small cell lung cancer. And the RT-PCR for EGFR was done, FISH for ALK was done, and hotspot NGS assay was done, and PD-L1 assay was also done. The report came that the patient had a exon 18 mutation in the RT-PCR based testing, where it was G719X, and it was negative for ALK, and PD-L1 was 10% positive. Whereas the hotspot NGS test did not show this EGFR mutation, and it showed a TP53 mutation along with a very high tumor mutation burden of 19.7%. Now, here is a regular dilemma one the clinician has to face, whether to rely on the EGFR, which is based on the RT-PCR, or rely on the NGS report, where you would have to give a different treatment of immunotherapy. So what was done was a comprehensive genomic profiling, and in fact, it was found that the patient had 3 different EGFR mutations in the exon 18, and the tumor mutation burden was just 8. So the dilemma of what testing should be done was what therapy has to be given was finally was in favor of EGFR mutation based therapy. Now, what did we understand from this? Number one, not all NGS panels are the same, because the TMB, which was estimated, and the EGFR negativity was also an NGS panel, whereas the CGP was also an NGS panel. So there is a very significant difference between different types of next generation sequencing panels. And more importantly, the TMB estimation, tumor mutation burden estimation, requires appropriate panel size and a lot of bioinformatic expertise. So the take-home message I would say here is clear understanding of the panel, the test, and their advantages and limitations is critical before choosing the appropriate test for a patient. So what is this comprehensive genomic profiling that really helped here? Here is a cartoon where on the top you see certain numbers. These numbers are the size of the genome. So 1 corresponds to DNA at a single base level, whereas 10 to the power of 4, 5 are all at a gene level, where you have thousands of DNA bases compiling a sequence, whereas 10 to the power of 9 is at a chromosomal level. Now, cancer can be a result of genetic aberrations at all of these genomic organization levels, and you have a variety of technologies to identify such genetic aberrations. Now, which technology is suited for what is what this cartoon represents, and PCR-based methods, also the Sanger sequencing-based methods, are good to identify genetic aberrations up to 1,000 bases long, whereas MLPA-like methods are good to somewhere in the gene level, where 10 to the power of 4 to 10 to the power of 6 it can identify, whereas the FISH karyotyping and the cytogenetic techniques are good at a higher order of the genomic organization, where you have large deletions or duplications. Theoretically, next generation sequencing can pick up genetic aberrations at the entire spectrum of genomic organization. And it is this technology that paved the way for comprehensive genomic sequencing. Now, all these technologies can be categorized into 3 major classes. One is the category 1 type of techniques, such as PCRs, real-time PCRs, FISH, and immunohistochemistry, which typically identify 1 mutation out of the entire spectrum of possible mutations in a gene. Category 2 are again NGS-based tests, but they are hotspot tests where you don't screen for entirety of the gene. You screen for very specific mutations within the gene, which are known to be more prevalent. So there is still a possibility of false negativity in these kind of hotspot panels. Whereas you have the category 3 type of technologies, where you can pick up every type of mutation that could occur in a gene using this type of panel. So there is no stone turned unleft in this type of a testing. So the definition of comprehensive genomic profiling has been evolving, and currently the accepted definition is that it's a multi-gene panel with more than 300 genes, picks up all major classes of genetic variants. It also estimates TMB, MSI, and covers the entirety of the genes included in the panel. So why to use CGP? I'll just show a couple of data point studies where you see in one study of 400 cases of EGFR exon 19 identified by CGP, 77 of them had previous testing results, and 22% of the test, those cases were false negatives in the standard of care type of test, which is typically the PCR-based test. Similarly, another study also corroborated that, where 21% of the cases had a false negative for EGFR. Likewise, if you come to ALK, which is a fusion-based testing, you see that of the 1,070 patients, 47 had ALK rearrangements and 31 had prior FISH positivity. 35% of the cases were false negatives by FISH. So this is the limitation of every technology, and the CGP definitely helps one to effectively identify every type of genetic alteration. So the summary of this section is that immunohistochemistries and FISH do play a major role. it has a complementary role when you do it with a CGP, because the comprehensive genomic profile can pick up every marker, detect several markers and genomic signatures at once. It helps you avoid tissue exhaustion, and it also helps in saving time. So next section, we'll move on to the case 2. We'll start with the case 2, where here it's again a 52-year-old female with stage 4 lung adenocarcinoma. EGFR negative, ALK and ROS1 negative, PD-L1 was high. The patient was started on the classical immune checkpoint inhibitor with a platinum combination. But unfortunately, within 2 cycles, the patient showed progressive disease, and that's when the comprehensive genomic profiling was done, and the patient actually had a MET exon 14 skipping mutation. So this MET exon 14 skipping, as we know, is a targetable mutation. The patient was started on capmatinib, and she really had a good response to it. Now, what do we understand from here? The major take home, I would say, is PD-L1 testing alone might not always be a very rigorous biomarker for all the cases that you might see in the clinic. So what does that mean? Biomarker testing for immunotherapy has 3 major approved biomarkers. One is the PD-L1 expression, microsatellite instability, and the tumor mutation burden. So we have a very, 4 major types of PD-L1 platforms, of which 3 are currently available in India: the 22C3, SP263, and SP142. And each of them have very specific type of scoring algorithm and the drugs associated with it. The tumor proportion scoring is basically the percent, how many tumor cells are staining with the partial or showing a partial or complete PD-L1 staining. Combined positive score includes tumor cells along with the immune cells that are there in the tissue, which are PD-L1 positive. These 2 are used for the 22C3 platform, whereas the tumor cell staining and the immune cell staining, as the name implies, are the percentage of the cells of the tumor or the immune cells which are positive for PD-L1, which is typically used for the SP263 or the SP142, 142 PD-L1 clones. Now, a very interesting study of the interchangeability, the Blueprint 2 study, showed that if the objective is to where they compared the PD-L1 clones, and they found that if you're looking for tumor cell staining, the TPS scoring or the TC scoring, the 22C3, SP263, and 288 are interchangeable, whereas the SP142 had a much lower pickup. So if the objective is to look for a TPS or a TC scoring, these 3 clones are interchangeable as per this study, although based on the drugs have a different approval in FDA for different clones. The tumor mutation burden is another complex genomic marker which typically looks for acquired mutations across a specific region of the genome and gives the frequency of the mutation, which is expressed as so many mutations per megabase of the genome. Typically, when you have a high TMB, it means that neoantigen load is high, and the high neoantigen load gives a better response to immune checkpoint inhibitor. But this marker also has its own set of challenges, like lack of standardization of how to estimate the TMB. Tissue-specific variation in TMB is well noted. So, for example, certain tissues like melanoma tissues or lung tissues tend to have a higher TMB compared to tissues like that of a sarcoma. And heterogeneity within the tumors is also there, and different sequencing platforms and different panels tend to give a different estimate. So, in fact, the first case that I described did estimate TMB, but it was a wrong estimate because the panel size was much lower. So there are certain harmonization projects going where the TMB estimation is being harmonized, and standardization is consensus on a standardization is coming into the play. So although you have the 3 markers, they rarely overlap with each other, the PD-L1, TMB, and the MSI. Or if anybody has a good overlap, and those are the patients that have the best response. Of course, independently also, these markers have their own capacity to predict a good response to immunotherapy. Next, I'll move to the 3rd case, where 6'2" male with non-small cell lung cancer, PD-L1 was high, and immunotherapy was initiated, but progression happened. There was a moderate response, and progression happened at 5 months, at which time a comprehensive genomic profiling was done, and the patient had a PBRM1 mutation, RB1 mutation, and a TP53 mutation. Now, if you go into the details of this PBRM1 is actually a marker, a component of the epigenetic histone modifier in the human nucleus, and that affects the various genes that are being expressed in the cell. And a very nice study in 2021 of 350 non-small cell lung cancer cases treated with immune checkpoint inhibitor showed that those with a mutation tend to have a much lower overall survival and PFS to immune checkpoint inhibitor compared to the wild type or those who don't have the PBRM1 mutation. And studies have shown that PBRM1 prevents or reduces the number of CD4 and the CD8 cells to the site of tissue, the tumor tissue. So typically it means that PBRM1 is a predictor of poor response to immune checkpoint inhibitor. And in this case, there was also an RB1 mutation, which is a very strong predictor for small cell transformation. So the take-home message here is there are factors outside or other than PD-L1, TMB, and MSI, which can also contribute considerably to predict the response to immune checkpoint inhibitors. So there are certain markers like neoantigen load, which typically, instead of looking at TMB, it predicts whether a mutation can become a neoantigen, lead to a neoantigen production in the protein at a protein level. So that load, tumor infiltrating lymphocyte levels, and somatic mutations in specific genes, just like how we saw the PBRM1 in the previous case, are all upcoming biomarkers under investigation that are that have the possibility of predicting response to immune checkpoint inhibitor. So next, I'll move on to the fourth case, which is a larger case, a long-standing case. From 2017, a 52-year-old male had a interstitial lung disease. It was identified to be non-small cell lung cancer. Was treated with cisplatin and pemetrexed in 2018. Had a radiotherapy, and in 2021 had a recurrence, and tissue testing of CGP was done, based on which he was given carboplatin nab-paclitaxel combination. And there was a good response. And again, in February 22, had a residual disease being identified. And in July 22, patient presented with severe body pain with hemoptysis, at which time a liquid biopsy was done. And this was the result of the liquid biopsy, where the patient had a MET amplification, BRAF mutation, DNMT3A loss, and a TP53 mutation. So of this, the variant allele fraction of the BRAF and the DNMT3A were very low, but the MET amplification copy number was very high. And this case was taken to a molecular tumor board, where it was suggested to add a MET inhibitor along with the ongoing immune checkpoint inhibitor. And based on the recommendations of the tumor board, the patient was added, a capmatinib was added to the regimen. And 6 months post-therapy, there is still no progression, and the clinical features have improved for the patient. So what did we see in this particular case is CGP is not only applicable to early cases, it also is early stages of the disease. It is also very important at late stages of disease. Molecular tumor board discussion gives a very deep insights into the therapy, and a validated liquid biopsy test can really be used in cases where tissue is unavailable. So the comprehensive genomic profiling really drives precision medicine. So what precision medicine is all about is that from a one drug fits all approach like that of chemotherapy, we moved on to the next type of therapy called one patient, one biomarker, one drug, say a PD-L1 testing and giving an immunotherapy. Whereas now we are moving towards one patient, one tumor profile, and more options. So you look into the biology of the tumor, look at pathways that are altered, and design therapies based on the pathways. So as Dr. Vivek Subbiah said in ASCO 2020, if you're serious about treating cancer, you need to have all information available, and genomic data is one such very important integral part of that information. So this a very interesting study last year came in, where a 9-headed hydra was taken as an analog to a tumor, and each head of the hydra is one pathway that you see in the tumor. So if you target one pathway, if you slay one head of the hydra, another pathway or another head grows in the hydra. So it is very important that futuristically, when you give an N of 1 approach, so as many pathways are activated, if you target each one of them, then one might be able to give a much better response, see a much better response in the patient. How is that feasible? in a multidisciplinary approach called molecular tumor board, where you have clinical oncology divisions, you have organ specialties, pathology, molecular biology, and clinical geneticists coming together, discussing a case and identify the best next option available for the patient. And this was in fact identified in a study where in the University of Kentucky, they had two groups of patients, one all non-small cell lung cancer. One group treated with the standard of care, the other group treated with therapy recommended by a molecular tumor board. And there was a very significant difference in those treated with the molecular tumor board having a much better probability of survival. So to close it, I would state this this image from the Art of War book. Victorious warriors win first and then go to war, while defeated warriors go to war first and then seek to win. So here the battleground is the cancer landscape, and one should have every information about the battleground before going into the battle. With this, I thank you all for this opportunity, and I'll be very happy to answer any questions.
Dr. Arun, thank you for such wonderful presentation. And so there are 2-3 things which I would like to ask you. One is that what is the percentage of the TP53 gene mutations which you find in the Foundation 1? What is the average? Because there are, when I get reports, I get like 5 to 7 gene mutations at least in most of my Foundation 1 report. So that's one question. So
Yes,
do you have any data with respect to that?
TP53 mutation, again, it varies with the type of cancer, but yes, in lung cancer, in also certain types of endometrial cancers, we do see that pretty common, TP53. Say even up to 65–70% of the cases, we do see TP53 mutations. But again, it goes a bit deeper than that. There are certain mutations in TP53 which have a different biological effect compared to another set of mutations in the same gene again. So it's imperative for us to look into the type of mutation that is there and make the therapeutic strategies appropriate based on that. So yes, it is a common mutation, but it is also a very important prognosticator for the patient.
Okay. So like you mentioned the 9-headed hydra. So in fact, when we go for CGP, we actually tend to find out 9-headed, 10-headed hydras, and then we don't know which head actually is the actual culprit head and which is the bystander head. And so till now, especially because most of the Indian doctors are actually sending Foundation 1 not at the beginning, but by the time they would have already second line or beyond. So that is when I usually a doctor would be sending a CGP when the patient is desperate, they're trying to find out, and that is when they be sent. What my impression as an oncologist has been that when we try to send the samples at this point of time, so however, like I have sent around like 15–20 samples, and I have never been like really benefited with the CGP report. I think that is my impression. So is it like a general one, or what do you feel about this? Because that's kind of an impression I've had with the CGP reports. Getting 5 to 6 mutations, almost 70% time I will have these patients getting TP53 along with various other mutations. There would be some suggestions, but I've not been able to find a long-term survivor with CGP. So that is what I have done till now. So what is your take on this?
Very genuine question, doctor, because this is not something unique to you alone. I think more what we need to do here is more have a multidisciplinary team looking into the report. Because as soon as you see more than one mutation in a tumor, that means that at least 3–4 heads of the hydra are active, and we should be able to target them. So when you are out of your standard lines of therapy, it is imperative for us to strategize the treatment in such a way that every pathway is, at least majority of the pathways that are there in the tumor are targeted. So that is where really the molecular tumor boards and the interaction with molecular biologists and molecular oncologists like that of Dr. Amit Verma, it really can be helpful. So maybe case to case, if we can have a discussion, definitely we can try to
Thank you so much.
take it
Yeah.
forward.
Very good talk, I think, and I must congratulate you for bringing such extensive data on CGP and Foundation One. And to add to what you have said, we have our own molecular oncologist who has been pioneer into building molecular tumor boards at the Max Institute of Cancer Care. We have Dr. Amit Verma. I don't think he is out of Max. He might be out of Max, but he's not out of Max people. So Dr. Amit Verma has been key person to whom we have been referring our patients, especially when we need to find these answers and what these findings mean on CGP or the hotspot panels, or what he thinks could be a better way to deal with our patients. So I'd like to invite Dr. Amit Verma for the next topic, which is new and emerging actionable biomarkers for targeted therapy in non-small cell lung cancer. Over to you, Dr. Amit.
Thank you, Dr. Sajjan, and thank you for the invitation. And I think the opening talk by Dr. Arun has been great. He started with the most advanced technology, that is a CGP, which is a US FDA approved test. So now, once we do such an exhaustive test, besides the common alterations, we tend to find something very rare alterations as well as other targets. So today my talk will be focusing on the new and the emerging actionable biomarkers for target therapies in non-small cell lung cancer. So we understand that the landscape of the lung cancer is changing continuously. And if I see that every year either the target or the drug is added with some significance and some relevance and some responses in the patient outcome. And if I see that this pie diagram on the left, you can see that the majority of the alterations, the EGFR, the actionable, and the other 25%, which are rare, but again actionable, we have a lot of drugs which are either approved or investigational, and among which we commonly practice the EGFR, ALK, and ROS. But other alterations like BRAF, RAT, MAT, and other like NTRK, MAC1, and PIK3CA are also coming up in a big way. So among the rare alterations or no actionable alterations which were earlier, now there are some set of alterations which are at very low frequencies but still actionable. And among them are the AKT alterations, the BRCA alterations in lung cancer, CDK4/6, FGFR, HRAS, KEAP1, KIT, mTOR, NRAS, NRG1, PDGFR, and PTEN. So I'm not going to dwell in each of the biomarkers, but a couple of them which have some relevance. And you can see that plenty of drugs are investigational in these categories. And for the FGFR, we have a pemigatinib, and for BRCA, we have rucaparib, talazoparib, which are already approved. So now we have such a plethora of targets and plethora of the target therapies. And this is where the handy test comes into picture, that what is a simplistic way which can give me answers in one go. And that lies down to the CGP. That is the comprehensive genomic profiling. But my talk is not on the CGP, but on the biomarker. So I will focus on the first important biomarker, which is the beyond EGFR, ALK, and ROS. The important one is the MET. MET, which is a very important receptor tyrosine kinase, very similar to EGFR, and which is the pathway which you can see. It activates multiple pathways which are downstream, primarily the MAP kinase, the NF-kappa B, the STAT, and the PIK3-AKT pathway as well. So practically, it's this particular alteration or the activation of this pathway leads to parallel of 4 pathways being activated. And that is why we are trying to target the MET alteration so that we can control the 4 pathways together. And as we understand that the pathway is normally activated by the ligand called HGF, but in the tumor, the MET is activated, which is a constitutive activation, either by a mutation called MET exon skipping 14 mutation or by MET amplification. So we have 2 important aspects, that is MET exon 14 mutation or MET amplification. Both can lead to the activation of this MET pathway. And interestingly, if you see the MET exon 14, what it does, it reduces the internalization and the degradation of MET receptor, leading to constitutive activity. So this is the basic mechanism. On the other hand, the MET amplification leads to the MET protein overexpression and can also drive the pathway of ERBB dependent activation of PIK3 signaling, especially in the scenario when the patient is also EGFR mutant and has received EGFR TKI. So MET amplification has come out to be a secondary mechanism for EGFR TKI resistance. So we have to understand that these are the two basic mechanisms. So the characteristic of this MET exon 14 alteration is very, very unique. These are the called exon 13 and exon 14. And this is the intronic region between 13 and 14 and 14 and 15. So this 200 base pair, which is a very hotspot area in this area, that is the junction of the intron exon boundary of 14 and the 13 is altered, and the 14 and the 15 is altered. So if either of the alterations seen in this leads to the skipping of exon 14, and this leads to the MET exon mutation, what we are talking about. So this is the basics. The interesting part is that it is seen in up to 4% of non-small cell lung cancer. So the frequency is quite acceptable, similar to the ROS or the ALK, what we normally see. Not that high like ALK, but still half of the ALK MET exon skipping can be observed. So there are plenty of methodology which can be used, either the NGS or the Sanger sequencing or RT-PCR or RNA sequencing or whole exome sequencing. So practically speaking, we have two methods, that is the DNA-based method or RNA-based method to identify the MET mutations. Interestingly, non-small cell lung cancer with sarcomatous histology tend to have MET exon 14 mutations quite common. So whenever you see a histology representing sarcomatoid, you also should emphasize on getting the important test of MET exon 14, and the percentage can go up to almost like 30 to 31 to 32% in sarcomatoid, the presence of this mutation actually. So as I said, that there are 10 alterations, more than 150 alterations have been reported, and these are at the DNA level, which leads to the exon 14 deletion or skipping. And you can see these are the important sites, and these are sites called the acceptor site or the donor site, which whenever they are deleted leads to this splicing of this exon. Besides the MET amplification, the second alteration, which is normally seen in up to 6% of non-small cell lung cancer, especially when they are treated with EGFR inhibitor. And there are certain reports that the level of the copy number gain varies depending upon the cutoff used actually. And the relevant copy number gain is more than 10 for us to see responses by using the MET inhibitors. And the technology used is primarily FISH, but other technologies like PCR can also be used to find the MET amplification. So we also have to understand that the MET amplification has been reported in up to 30% of MET exon 14 skipping lung cancer. So you may end up having co-occurrence of these mutations, that is the MET exon 14 and MET amplification, and it has to be dealt accordingly. So as I said, that we have two methods, the RNA-based method and the DNA-based method. And you can see the RNA-based method, the exon 14 is not there, but you see a fusion of 13 and 15, and this is how the test is being conducted. On the other hand, the DNA-based NGS platform analyze the genomic alterations and then see the implications of genomic alterations in splicing the exon 14. So this is the way the DNA is being analyzed. And RNA-based tests, we have RT-PCR or RNA sequencing, but in the DNA, we have a standard PCR or the DNA sequencing. So we understand that this drug, capmatinib, has shown a beautiful result for MET exon 14, and is already approved. And you can see this waterfall plot where a substantial reduction or clinical benefit is observed. And based on the Geometry Mono-1 trial, FDA approved Foundation 1 CDX is a companion diagnostic to capmatinib in lung cancer. So we have to be very, very particular for the companion diagnostics which we should be aware of. Similarly, we have tepotinib, and tepotinib, you can see such a beautiful waterfall plot showing good responses. So now, similar to MET, we also have a RET fusion, and quite commonly seen in less than 5% of the lung cancer cases. And you have technologies like NGS, FISH or PCR to detect the RET alterations. And we have RET kinase inhibitors available like selpercatinib. You can see such a beautiful response to the RET inhibitor, selpercatinib. And a similar drug called pralsetinib in this ARROW trial shows a very good response percentage and response rate in the non-small lung cancer actually. So a rare alteration, but can be picked up by these special tests, which I just mentioned. It can be NGS, FISH, or PCR. So now let's come to the NTRK, which we know that it is a tissue agnostic test, and this is a tissue agnostic biomarker. But if you see this in lung cancer, this neurotropic tropomyosin receptor kinase is seen in less than 1%. And the alteration, what we are looking at is the fusion. So we have to be very, very specific that we are looking at the fusion, not the mutation, which is the driving alteration in the non-small cell lung cancer. And we have the next generation sequencing technologies. Again, the fusion technologies, RNA-based is considered to be the best. And we have other investigations like FISH and RT-PCR, which are also very, very useful. So basically, there is a screening tool which we all should be aware of that is called the NTRK IHC, which can see the overexpression of the NTRK fusion byproduct. Once you see the NTRK IHC to be positive, it is considered to be a screening test, which needs to be confirmed by orthogonal NGS test before starting the treatment. The common NTRK fusion seen in the lung cancer is NTRK1 and NTRK3. We rarely see NTRK2 fusions in lung cancer. NTRK2 fusions are normally seen in brain tumors. So we have the first generation TRK inhibitors, larotrectinib and entrectinib, and we also have second generation TRK inhibitors at the same time. So let us talk about the NTRK mutations. The NTRK mutations are not the primary NTRK driver alterations, but they are the secondary mutations which are developed after the utility of the first generation TRK inhibitors like larotrectinib and entrectinib. And we have next generation TRK inhibitors like selitrectinib, repotrectinib, and telitrectinib, which can inhibit NTRK as well as ROS and ALK, like repotrectinib is a triple TKI. So this can be very, very useful, especially when you hit a secondary alteration. So whenever you are looking for the NTRK interpretation, you should always look for the NTRK fusion. And if you treat the patient with first generation and response is lost, then look for secondary mutation. So these are called the on-target mechanisms. And we also have the off-target mechanisms like RAS, RAF, and MEK. These alterations can also lead to NTRK resistance. So that's a different discussion. But so we have a very important biomarker called KRAS, and we know that the KRAS is seen in up to 30% of the non-small cell lung cancer, among which that is up to 40% times the KRAS tends to be G12C. So most of the KRAS is seen in codon 12, and G12C is quite commonly seen in lung cancer, and the total number of KRAS G12C is reported to be approximately in the range of 13%. So it's a very, very important number, and we understand the finding an alteration for the KRAS mutation is very difficult because of the lack of deep binding pocket, but there are drugs which is called sotorasib, and we have a drug called adagrasib, which are available for the KRAS G12C alteration. But we have to understand what method we have to do before we can label them the ideal patient for these therapies, which are the companion diagnostics. So QIAGEN TheraScreen is used to identify the KRAS alteration in tissue for either sotorasib or the adagrasib. But if somebody wants to use a liquid biopsy, then Guardant 360 is considered to be a companion diagnostic for sotorasib, and the Agilent Resolution CTDX first assay, which is again a liquid biopsy companion diagnostic. So we have to be sure what we are talking about, and the results have been shown very beautifully. Like sotorasib showed response rate of 37% in the CodeBreak 100 phase 2 trial, and Crystal-1 shows a response rate of 45% overall response rate. So now we have interesting biomarker called HER2, And in lung cancer, we see HER2 mutations more than the HER2 amplification, which is seen in 2% of the lung cancer cases. And we have this new drug called pyrotinib with a response rate in the range of 20%. We may have HER2 mutations in exon 20 or without exon 20, and the response rate may vary in the range of 18 to 25% respectively. So exon 20 mutations in HER2 are a little tricky to treat and respond. And if you see the drugs like TDM1 shows a response rate in the range of 44%, and the patients who are HER2 overexpressing, that is the HER2 expression based on the IHC, the response rate of the TDM1 is in the range of 20%. So to summarize here, this observation that the HER2 mutations can be handled by the TDM1 as compared to the overexpression alone. The other drug, which we all are familiar, which is a more potent drug called TDXD, which is now being discussed for the HER2 positive lung cancer. And the response rate is quite high in the range of 62%. And you can see the duration of response is quite good and even giving the benefit in terms of overall survival. And FDA has recently granted this trastuzumab deruxtecan for HER2 mutant lung cancer. So now we have interesting biomarker called NRG1. NRG1 fusions are again very rare to find, less than 1%. It is basically a drug which is against the anti-ERBB3, which is the NRG basically leads to the activation of ERBB3 and ERBB4 pathways along with the HER2. And this is the therapy which is against the ERBB3, and it is under right now development. And there are two drugs which are being discussed, and one already got approval called zenocutuzumab, which is approved in metastatic solid tumor harboring NRG1 fusion, irrespective of the tumor type, whether it is pancreatic cancer or lung cancer. And this is something which is very kind of a tissue agnostic drug approval, what it has received. It was in the year 21 actually. And we have another pan-HER tyrosine kinase inhibitor called tarloxtinib, and again, which is against NRG1 fusion proteins actually. So now we have interesting biomarker, which is against the KEAP1 or the KEAP1 NFE2L2 pathway. So this particular pathway is seen to affect the immune response and is responsible. You can see that this diagram here, whenever the NRF2 pathway is activated, the C-gastric pathway is inhibited actually. And this leads to the immunosuppressive environment, which leads to lack of response to immunotherapies for that matter. And not only this KEAP1 biomarker is a biomarker for lack of response to immunotherapy, but also a predictive biomarker to radiation resistance, and also a mechanism of acquired resistance to target therapy, especially EGFR therapies actually. And there's a drug which is called sapanisertib. It's a very new drug which is blocking both mTOR-C1 and mTOR-C2 pathways together. And it has been shown that this drug is superior to everolimus for that matter. There's another drug called glutaminase inhibitor, which is under being investigated, which can address the KEAP1 activation pathway. Similarly, we have the STK11 alteration, which is seen in up to 39% of the lung cancer, quite common. And whenever you see both STK11 and KEAP1 alteration, which is quite prevalent in lung cancer, you can predict that the patient will not respond to ICI that much. And there are drugs which are acting against the STK11 currently being developed actually. And we also have FGFR1 mutation which are observed in lung cancer in a very low frequency though, and there are drugs which are being developed as discussed earlier. So now there are biomarkers which can help to combine the target therapies with immune therapies. So one of the important biomarkers is called the STING expression, and STING stands for the stimulator of interferon genes. And this is basically activated by the cytosolic DNA fragment. If you see a high expression of the STING pathway, you can predict that the patient may respond to combination of the PDL1 and a target therapy against the DNA damage repair, that is PARP inhibitors. And so this can also serve as a biomarker to respond to the combination of immunotherapy and the platinum therapies actually, and is associated with the overall improved survival in local adenocarcinoma of lung. And similarly, we have two important biomarkers, LAG3 and FGFL1, and they are again promising immune checkpoint inhibitors, which we understand. But these important high expression of these two important biomarkers are associated with the poor 5-year survival, and also there's a drug which is a targeted drug called irinotecan monotherapy, or in combination with immunotherapy, is currently being used, and there is a direction that the combination of these drugs, anti-LAG3 or anti-FGFR1/3, anti-FGL1 inhibitors, make sense in combination with the immunotherapy or immune checkpoint inhibitors. And now again, similarly, we have a TIGIT target, and TIGIT target is again a T-cell immunoreceptor with IgN, ITM domains, which are basically the immunoglobulin proteins, and overexpression is suggestive of immunosuppressive environment. And the drugs, TIGIT inhibitors like tiragolumab with atezolizumab shows, you can say, a better PFS, which is seen in this CITYSCAPE trial. And similarly, there's another called vivostulimab, which is again an anti-TIGIT drug, which is being combined with pembrolizumab for the better response to immunotherapy. So again, the new targeted therapy
My
approaches
apologies, sir. You
based on
need to
the
conclude your
biomarker.
session in 1 minute.
Okay, thank you. So I'm almost done. So biomarkers are basically being discussed depending upon the individual country guidelines, but we normally follow the NCCN guidelines and different methods. But broad-based testing is what I personally recommend, or also recommended by the NCCN. And different alterations, different frequencies, and different methods are available. And this is a chart which talks about what I have just said in my previous slide. Just to give you a flavor of the types of tests what we normally do, and we are able to find the rare alterations like in this lung cancer, these KRRL anti-RK fusion, a very unique partner was identified in this particular case. And similarly, the same alterations can be easily picked up in the liquid biopsy. So very interestingly, that liquid biopsy is good enough to pick up the fusions. And now we have this NRG1 fusion, CD74, which we were talking about, again, another rare alteration. These two cases are coming from the clinic. So rare alteration can be picked up when we used the comprehensive genome profiling as the mode of investigation. With that, thank you, and over to the organizer.
Thank you, Dr. Amit, for such elaborate presentation and taking us through the landscape of lung cancer and how it has been evolving over the last 3 to 4 years. So my question to you is that what about the KRAS? Because we only have with one mutation. So does the drug work against other mutations if we have some other mutation like 12D, or it does not work?
So the sotorasib is very uniquely made for this G12C. It does not work for the other alteration. But yes, for HRAS mutation, the farnesol inhibitor TP-FARNib has been approved. But for KRAS and HRAS, which are of the same family, it is very difficult to find the inhibitors, but they are being developed as of now. But right now, we can only say that this particular mutation G12C is the only target what we have.
Thank you so much again for accepting this invitation and for the lovely talk. And look forward to hear more and more from you at each lung meeting. Thank you, Dr. Amit.
Thank you. Thank you.
So we have the next talk again covering the another important domain, which is the immunotherapy domain. So we have Dr. Anuradha Chogle from Mumbai, and she will be speaking on biomarkers predicting response to immunotherapy-based regimens, especially on PD-L1.
Yeah. Thank you, Dr. Rajpurai. for giving me this opportunity to present the biomarkers, upcoming biomarkers, and especially you can see the paradigm shift happening from chemotherapy to targeted therapies and now with the immunotherapy. So let us have the look at the PDL1, what it is. And I will give an overview of PDL1, CTLA4, how the testing is being done in the lab, and what is the scoring system. And also, I will talk upon the targeted therapies against this, the immunotherapies, ICI, against these markers. So lung cancer, as you know, has undergone a paradigm shift, substantial improvement in survival lifetime, and the quality of life has improved definitely. And the treatment of advanced of NSCLC has evolved from the empiric use of chemotherapy to armamentarium of tailored approaches. And the immunotherapy that is represented by ICI, what it is called as immune checkpoint inhibitors, mainly refers to the PD1 and PDL1 blockades. So the subsets of these patients treated according to the genetic alterations of the tumor and the status of PDL1 will be looked upon in this my talk. So the immune checkpoints such as cytotoxic T lymphocytes, associated protein 4, that is CTLA4, and PD1 are the co-inhibitory receptors present on the activated T cells. So here is a pictorial diagram of the PD1 where you can see the checkpoint proteins such as PDL1 on tumor cells and PD1 on the T cells, which helps keeps the immune response in check. The binding of this PDL1 to PD1 keeps T cells from killing tumor cells in the body. However, if you block this, the binding of this PDL1 to PDL1 with an ICI, that is immune checkpoint inhibitors, allows the T cells to kill the tumor cells. So what is the pathophysiology of this? So this PDL1 is which is an immune checkpoint protein, regulates the immune response to prevent excessive chronic autoimmune inflammation, normally expressed on activated immune cells, that is the antigen presenting the cells, that is APC, what we normally call as, and the B cells. So it binds a regulatory surface PD1 and B7 on CD8 T cells. It inhibits the T cell activation and induces the T cell exhaustion. That is, the cancers can express PDL1 as an adaptive immune resistant mechanism to attenuate the host anti-tumor immune response. Selective blockade of this PD1 and PDL1 axis is used as a therapeutic strategy in the treatment of multiple cancers to prevent T cell inhibition and reactive T cell mediated tumor cell. So what are the antibodies which are available in the market and how they are used for the different target of the ICI? So if we are going to target the PD1, PDL1 assay with the antibody DACO22C3, then normally the pembrolizumab, if you are using the pembrolizumab, we need to have the antibody like DACO22C3. And if you are using the nivolumab, then DACO28-8 for the PD1 is used. For the durvalumab, it is the Ventana, which is SP263 is being used. And for atezolizumab, it is the Ventana SP142. Now, if there are how the cell type is scored. So suppose NSCLC we talk upon, then we need to make the scoring on the NSCLC tumor cells. So particularly same thing is observed in nivolumab, durvalumab. So what is the cutoff value been taken into consideration? So it is 1 to 49%, and if it is more than 50%. Same goes with the pembrolizumab. But again with the nivolumab, if the tumor cell is more than 1%, if it is the more than 5%, FTC is 10%, we can consider it. But if you are administering durvalumab, then the TC has to be more than 25%. In case of atezolizumab, it is the TC or IC should be more than 1% or 5%, 50%, or more than 10%. So coming to that,
Anuradha, can you make it full screen?
Yeah.
Thank you. Okay.
Yeah. So for this unique IHC assay for each immune checkpoint inhibitors, 4 PD-L1 IHC for assays are registered with the FDA using 4 different PD-L1 antibodies. As I mentioned, 22C3 to 2828, SP263, and SP143 on 2 different IHC platforms, that is the DACO and Ventana. And definition of positive varies which biomarker assay is used and for which malignancy, as I mentioned in my the chart. So the PD-L1 expression by IHC, so the tumor proportion score, that is the TPS, how is it being done? That the ratio of the number of PD-L1 expressing tumor cells to that of all tumor cells, then no role as predictive indicator except the NSCLC for pembrolizumab. So and the mononuclear immune cell density score, that is MIDS, ratio of the number of the PD-L1 expressing immune cells to that of all tumor cells. So if you go to see the combined positive score, the ratio of the number of all PD-L1 expressing cells, that is tumor cells, lymphocytes, macrophages, to the number of all tumor cells at the denominator. So this is how the CPS is measured, that is number of PD-L1 stained cells, that is the tumor cells, lymphocytes, and macrophages at the numerator, and at the denominator you look upon the total number of variable tumor cells, viable cells, into 100%. So the minimum 100 viable tumor cells must be present in the PD-L1 stained slide, that is the section tumor biopsy or resection tissue, for the specimen to be considered adequate for evaluation. As per the NCCN guidelines, for the use of immunotherapy in metastatic NSCLC and negative driver mutations, that is EGFR, AL, CROS, and BRAF, V600E, we should go for the immunotherapy. Patients with PD-L1 expression more than 50% are recommended to receive single agent like pembrolizumab, regardless of histology, as first-line treatment. And the second, single agent pembrolizumab can also be used as first-line therapy in patients with metastatic carcinoma and PD-L1 levels of 1 to 49%, regardless of histology. So the combination of pembrolizumab and chemotherapy as first-line therapy, which is regardless of PD-L1 expression. For subsequent therapy options, pembrolizumab is recommended as therapy options in patients with metastatic NSCLC and PD-L1 expression more than 1%. So the nivolumab or atezolizumab can be used as a subsequent therapy regardless of PD-L1 level. Now coming to the CTLA4 with this pictorial diagram, you can see the checkpoint proteins of B71 and B72 on antigen presenting cells, that is the APC, keeps the body's immune response in check. When the TCR binds to the antigen and the MHC, the APC and CD28 on the APC and CD28, it binds to the B71 and B72, the T cell gets activated. The binding of this B71 and B72 to CTLA4 keeps the T cell in the inactivated state. However, blocking the binding of this B71 and B72 to CTLA4 with an immune check inhibitors allows the T cell to be active and it keeps the to kill the tumor cell. So this is how it goes with the CTLA4 and B7. Coming to the clinical features of PD-L1 is the companion diagnostic to pembrolizumab, a humanized monoclonal PD-1 blocking antibody. However, the FDA approval for pembrolizumab for NSCLC based on results of Keynote 010 and Keynote 024 clinical trials have been administered. So pembrolizumab have been successful. Pembrolizumab is indicated for the patient with metastatic NSCLC whose tumors have high PD-L1 expression, that is more than 50%, but however, there should be no targeting mutation present like EGFR ALK on the genomic tumor aberration, and there should be no prior systemic chemotherapy treatment for metastatic NSCLC. So pembrolizumab is indicated for the patient with NSCLC whose tumors express PD-L1. Here is the drug ipilimumab when it is a stage 4, which at the first line in combination with nivolumab, if tumor PD-L1 is 1%, but however there should be no EGFR ALK mutation. This is with the FDA approved indication in combination with nivolumab and 2 cycles of platinum doublet chemotherapy. With the EMA indications in combination with nivolumab and 2 cycles of platinum doublet chemotherapy with no EGFR ALK mutation. Considering the nivolumab with the stage 4 first line in combination with ipilimumab, if tumor PD-L1 is 1%, it can be administered in combination with ipilimumab and 2 cycles of platinum doublet chemotherapy is the standard indication by the FDA. However, EMA indicates that in combination with ipilimumab and 2 cycles of platinum doublet chemotherapy, again it's similar to the FDA approval. Coming to the stage 4 in the second line for the nivolumab is as single agent if progression on or after platinum based chemotherapy can be used, and if EGFR ALK mutation is present, or a single agent if progression on corresponding with the FDA approved therapy can be given. Again, as single agent if progression on or after chemotherapy. Considering that durvalumab, whether the stage 3A and B after the chemotherapy and architherapy, if the disease not progressed following concurrent platinum-based chemotherapy, chemoradiotherapy can be given, and if again, with the EMA indication, disease not progressed following platinum-based chemoradiotherapy, if tumor is PDL more than 1%. Coming to the pembrolizumab with the stage 3 and 4 at the first line in combination with pemetrexed plus platinum chemotherapy in NSCLC histology, again no EGFR ALK mutation should be present, in combination with carboplatin and nab-paclitaxel in squamous histology. As a single agent, if tumor PD-L1 is present, again there should be no EGFR ALK present in the first line. EMA indication in combination with pemetrexed platinum plus chemotherapy with no EGFR and ALK, in combination with carboplatin, nab-paclitaxel in squamous histology, it should be as a single agent if tumor PD-L1 is more than 50%. Coming to the pembrolizumab as a second line, as a single by the FDA indication as a single agent if tumor is PD-L1 more than 1% at progression on or after platinum-based chemotherapy. If EGFR ALK mutation as a single agent if tumor PD-L1 % and progression on corresponding FDA approved therapy can be administered. Considering the EMA indication as a single agent if tumor PD-L1 is 1% at progression after 1 prior chemotherapy, and if EGFR ALK mutation then present as single in the second line as single agent if tumor PD-L1 is more than 1% and progression after 1 prior chemotherapy and targeted therapy. I won't go much into the detail of this chemiplimab. I think when it is in the stage 3 and 4, it is considered. Then a single agent if tumor PD-L1 50% with no EGFR ROS ALK mutation should be present, and same goes with the EMA. So this is the study report prolonged how the immunotherapy versus chemotherapy. So in a recent report, it has been evaluated that the baseline blood tumor mutation burden and specific DNA genetic mutation using a 500 gene NGS panel. It was a case study it was a literature by Agarwal et al. In 66 patients receiving first-time pembrolizumab based treatment. So the combination of blood tumor mutation burden and the absence of negative indicator mutations such as STK11, KAPA, PTEN, and HER2 exon 20 was associated with the progression-free survival and overall survival benefit. Lamberti et al. Suggested that other factors compared to high PD-L1 tumors, negative PD-L1 tumors presented more than often, that is STK11 19% versus 5% with the p-value less than 0.001, EGFR 22% versus 11%, CTNNB 4% versus 0.4%, and the APC mutations, that is 5% versus 1% can be taken into consideration. So in a smaller subset receiving ICS, ICIS, the STK11 or EGFR mutations were also significantly associated with the shorter progression-free survival and overall survival. So the TMB is defined.
I
It
would
is
request you to conclude your presentation.
sure,
Bhavani.
sure.
Thank
So
you.
the major concerns of TMB are the high cost, long turnaround time, and needed expertise. Targeted panels have been used on both tissue and plasma specimen. However, the lung cancer tissue availability is also a major concern. And in blood of ctDNA, the ctDNA is very critical because the yield you get is very less. Coming to the tumor genotype, accumulating evidence suggests there's a possible positive or negative predictive role for other tumor mutations involved in various cancer pathways may improve the predictive ability of the PDL1 and TMB when combined. Actionable mutations in the driver oncogenes, EGFR, and ALK confer the resistance to ICI. Immunotarget retrospective analysis response to ICI therapy in metastatic can be also considered, like various oncogene present BRAF, MET, and ALK genes, and also the red rearrangement are also to be considered. And so this is my last slide. So the take home message is like the benefit of ICIs is not universal, and only a minority of patients experience the durable response. Accumulating evidence has shown that PD-L1 assay with the immunohistochemistry alone is not accurate or reliable enough to predict response to ICIS. Currently, the identification of alternative companion biomarker is a research priority. However, what is more likely is that the response to ICIS may depend on a set of factors like both host and tumor related that are involved in the complex immune anti-tumor control network. However, the unpredictable and paradoxical response in tumors of expansive tumor growth after ICI have also been observed as an hyperprogression. So it indicates that the primary required resistance to ICI may be due to poor patient selection and knowledge gap in the biological underpinning. Thank you.
Thank you so much, Dr. Anuradha, for comprehensively covering this topic. And I think with more biomarkers emerging, it will become really understandable as to which is the better way to predict the response to these PD-1 and as well as PD-L1 inhibitors, and also new class of or newer drugs in the CTLA domain. And I think we're also working towards newer biomarkers which would act in a similar checkpoint compared to PD-1 or PD-L1.
Yes,
So thank you
covered
so
by
much.
Dr. Amit Verma, the emerging immunotherapy biomarkers and the immunobiomarkers. Yeah, thank you so much.
Thank you so much, ma'am. Thank you so much. So we now move to the next part of the meeting, and this session is sponsored by AstraZeneca, and the talk will be by Dr. Aditya Murli from Bangalore. The topic is osimertinib as adjuvant therapy in patients with resected EGFR mutation positive stage 1B to 3A non-small cell lung cancer. Updates from the ADURA. Dr. Aditya Murli, welcome, and over to you.
Thank you, Dr. Sajan. It's such a pleasure to be a part of this event. I was a part of your event last year also, and thank you so much for having me around. I like to thank Horizon for having me on board, and AstraZeneca for helping me, not just prepare for this talk, but learn in the process. So I hope I am audible. My slides, just 1 second. I'm trying to see. Yep. My full screen is visible. Okay.
Yes, sir.
Yes, sir.
You're audible and visible.
Great. So over the next 10 to 15 minutes, I would talk about the updated results from the ADAURA trial. Now, there are two things which should stand out when we look at the opening slide. The first is here we have a trial which is talking about adjuvant therapy in lung cancer. So when I was training, there was only one treatment for adjuvant therapy in lung cancer, which was, there was one meta-analysis wherein the benefit was from 4 months to 6 months. So that was the greatest thing which all of us knew and none of us bothered too much about. So today we have moved from that day to the day wherein we are able to talk about adjuvant therapy in lung cancer. So that's the first big victory. The second victory of science here is that, we are talking about stage 1B as well. So it just means that it is worth fighting for each and every patient and testing each and every patient. So all of these latest advances have to be done in such a manner that they reach everyone. So phase 3 ADAURA was a phase 3 trial. It had a fairly straightforward inclusion criteria. Both exon 19 deletion and L858R were included in this. Brain imaging was necessary. The interesting thing to note in the inclusion criteria was that patient should have had either 10 weeks without adjuvant chemo. So that was the max interval between surgery and randomization. Or if a patient did receive adjuvant chemotherapy, 26 weeks should have been the maximum time between surgery and randomization. So to the straightforward 1:1 randomization, numbers were fairly okay, about 300, 340 in each arm. Osimertinib was 80 milligrams once daily for a total of 3 years. Versus placebo given once daily. The primary endpoint for this trial was disease-free survival, which was investigator assessed for stage 2 and stage 3A. So the primary endpoint DFS took only stage 2 and stage 3A, not the stage 1B. I'll talk about this later. So this was again designed for superiority under the assumed hazard of about 0.7. A key secondary endpoint was DFS at 2, 3, 4, and 5 years and overall survival. Now, a small caveat here is that we generally don't like adjuvant trials when the endpoint is anything but overall survival, because by definition, adjuvant therapy is to cure a patient. But in lung cancer, cures are something which none of us knew before. So this is a reasonable endpoint for us. So before I go on to the actual part of it, the data which was already available for the ADAURA, which was a primary analysis of the DFS benefit, this showed that in the intention to treat stage 2 to stage 3A population, the hazard was 0.17. Mind you, it's 0.17. And when we talk about most chemo trials, it is 0.7 or 0.8, and that is enough to get approval. So this is where there was overwhelming superiority demonstrated. When we added the stage 1B, the DFS, the hazard was still 0.2, which was quite astonishing. So the next few slides, I would talk about the analysis after all patients have had the opportunity to receive the full 3 years of adjuvant treatment. So in terms of baseline characteristics, the important thing to note over here is that, about 40% of the patients did not receive any adjuvant chemotherapy. And this was very well balanced in both the osimertinib and the placebo arm. So that was one. The second thing was even the ratio of exon 19 to L858R. So because there is a lot of talk these days about whether if a specific type of mutation is better treated by a specific type of TKI. So in this trial, it was fairly well balanced across both the arms, and it was a 55-45 split between exon 19 and L858R. This is a curve which should stand out to everyone who views this. This was the primary endpoint, updated disease-free survival of stage 2 and stage 3A disease. You can see the curves are separating as early as the second or the third month. So that is how early the curves are separating, and the benefit is maintained at the second year, at the third year, and at the fourth year mark as well. The hazard ratio over here was an astonishing 0.23. This was after all patients had completed their 3 years of adjuvant osimertinib. Again, when we look at the actual numbers, the median DFS was 65 months for osimertinib versus just about 22 months for the placebo arm. When we added the stage 1B also, because this trial did include stage 1B patients, when we added the stage 1B also, again, the hazard was 0.27 even at the end of the completed plant analysis, which just goes to show that the benefit of adjuvant osimertinib is not only long lasting, it is also available for patients who have a very early stage 1B disease. And this is a subset of patients who in a regular day would not even have gotten adjuvant chemotherapy. Very rarely we get to see forest plots like this, wherein every single subgroup is on this side of the forest plot, and be it whatever subgroup we look at, whether the patient had received adjuvant chemo or not, there was definite DFS benefit. Even if a patient had not received adjuvant chemo, the DFS benefit was 0.36. With adjuvant chemo, the DFS benefit was 0.29. So we actually don't know in the era of osimertinib, is there any role for an adjuvant chemotherapy also? But till now, NCCN guideline will say that there is adjuvant chemo followed by adjuvant osimertinib would be the choice over here. This was also there for patients who are smokers, non-smokers, across all single subgroups. So this curve, this slide looks at the DFS curves when patients were staged as per the 7th edition. We have all moved on to the 8th edition, and even if we look at the 8th edition, here what we can see is that in stage 1B there was early separation of curves, and the benefit was maintained even at the 4 or 5th year mark. The curves might be meeting over here, but the caveat is that the numbers are very, very small at this time. The number was basically 0. So rather than telling that we are trying to find the tail of the curve, what we need to show is even in stage 1B, wherein it is so hard to prove any benefit of any kind of adjuvant therapy, here is a molecule which definitely provides, not only provides benefit, but also starts providing benefit very early in its treatment lifetime, be it stage 2. And we know that in stage 3A, the disease is coming back. And here is where the magnitude of benefit is probably the highest, with a hazard of about 0.22. Again, when we looked at the patterns of disease recurrence, the important thing to note in the ADAURA trial was the most common first site of recurrence were the lung in about 12%, lymph nodes in about 6%, and CNS in about 6%. So what we in the osimertinib group versus CNS was about 11% in the adjuvant group. So moving on to the CNS part of it, and we all know why are we talking about CNS. That's primarily because we know that osimertinib has fantastic penetration through the blood-brain barrier, and it is one of the biggest reasons we choose osimertinib in metastatic patients with CNS disease. So even if a patient does not have CNS disease upfront, that is still a reasonable goal and a reason for us to pick this particular molecule. So overall, 63 patients of the 600 odd patients had some kind of a CNS event, which is about 10% of the patients. But if you see the number of patients who had a CNS event in osimertinib was literally half the number of patients who had a CNS event in the placebo arm. About 14% of the patients were on treatment at the time of CNS recurrence versus osimertinib versus 29% in the placebo arm. Again, very significant hazard of 0.24, which just goes to show that there is absolutely no reason why we should not pick osimertinib even in the adjuvant setting. So this slide talks about the conditional probability of CNS and non-CNS recurrences. The cumulative incidence of CNS recurrence was consistently lower in the osimertinib arm as compared to the placebo arm. When we talk about the stage 2 and 3A, especially in stage 3A, wherein we know that there is a good chance the patient might fail in the CNS, even in this, there is a fantastic benefit with osimertinib in this particular setting. Safety events. Now, no adjuvant discussion is complete without talking about safety events, because mind you, here we are giving all patients this particular drug, which has to be used for 3 complete years. So in terms of safety summary, the important thing that we need to look at is that if there are about 27% of the patients had some kind of a adverse event leading to dose interruption. However, when we looked at the dose discontinuation, only about 13% of the patients had to discontinue due to some kind of adverse event. So it's very, very important for us to note that even if we use this molecule for 3 full years, the discontinuation rates are about 13%, and the dose interruption or the dose reduction rates are also not very high. Obviously, we don't want any adjuvant deaths in our patients. So there was absolutely no adverse event which led to death in patients who were on the osimertinib arm, and only 3% of the patient had some kind of a serious adverse event. So what are the adverse events that we should be worried about? Interstitial lung disease is something that we need to look at, although the possibility is very, very less. We need to see that this is a small trial with small numbers. But then again, how many times in our own day-to-day clinical practice do we get early lung cancers who have been cut beautifully by the surgeon and come to us for treatment? So again, it's sort of tough to make sense of these numbers, but the things we need to look are the interstitial lung disease. It's not, this does not mean that we need to keep doing CT scans or chest x-rays at each visit. We will anyways do a reassessment scan, and that should be good enough. However, if a patient does has persistent cough, and that should be something that could alert us towards trying to do further imaging. Lung cancer is a disease of elderly, we like it or not, which means that QTc prolongation is an important thing that we may need to look for in patients who have got other comorbidities. However, JCO did have some data recently of using osimertinib in patients with pre-existing cardiac disease, and it has been shown to be quite safe in that subgroup of patients as well. So that should not be a hindrance for us to start using this. So to conclude my talk, in this updated disease-free survival analysis of osimertinib versus placebo, patients have been followed for a further 2 years and all had the opportunity to complete 3 years of the planned study treatment. Overall, there was 77% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo, with a hazard of about 0.23. The median DFS in the osimertinib arm was 65 months versus 21.9 months in the placebo arm. There was also a 73% reduction in the risk of disease recurrence or death with adjuvant osimertinib, and that for us is the goal of any adjuvant treatment. An improvement in DFS was seen regardless of whether the patient received prior adjuvant chemo or not, and that is something, that's a question which we need to explore in the future. Osimertinib demonstrated a clinically meaningful improvement in CNS DFS, which is very, very important, and quite importantly, the safety profile was also consistent with the established safety profile. Obviously, the only toxicity that we don't talk about here is the financial toxicity, but then again, AstraZeneca has been doing wonderful work in trying to bring the price down and make this drug more affordable to everyone. So these updated data reinforce adjuvant osimertinib as the standard of care for patients with EGFR mutant stage 1B to stage 3A non-small cell lung cancer after complete tumor resection with or without adjuvant chemotherapy, and this is also the US FDA label approval. Thank you all for a patient listening, and I'm happy to take any questions.
Thank you so much, Dr. Aditya Murli, for such lucid and enthusiastic presentation. And I can feel the happiness when you use such drugs, because such trials are always a pleasure for medical oncologists. So my question to you is, today when your surgical colleague sends you a patient, so the patient is stage 2 or stage 3 resected. So do you upfront go for osimertinib if the EGFR mutation comes positive, or you start with chemotherapy, take your time and send the mutation, and then once you finish 4 cycles, then you go for osimertinib? So what do you do in your clinical practice?
That's a very fair question, Dr. Sajan. So ASCO came out with a clinical practice guideline in treating non-small cell lung cancer recently. And as per that, although there is data to support eliminating chemotherapy, even today, standard of care is going to be adjuvant chemotherapy followed by some kind of a maintenance therapy. So if a patient is EGFR mutant, then adjuvant chemo followed by osimertinib, or if it's EGFR wild type, then adjuvant chemo followed by atezolizumab. So that has to be the standard of care today, but this might change hopefully when you do your next meeting like this.
Thank you so much for this answer. And I would like to thank you again for joining us, and keep joining us. And I'll also love to join you whenever you do a meeting. And it's always interacting with you. Lovely interacting always. Thank you so much.
Thanks. Good day.
So we move on to the next session. The next session is sponsored by J&J. And again, we are moving towards one more area, which was always unmet need. And I have my colleague and friend, Dr. Aditya Vidushi. And we are lucky that we are using this drug in clinical practice and trying to understand whether this drug is similar to the other EGFR TKI mutation drugs, or how does it really change the class of patients, which are though otherwise less in number, but is this drug an actual game changer? So The topic will be hidden EGFR threats, the role of amivantamab, and over to Dr. Aditya Vidushi for this talk.
Good evening, everyone. I would like to begin by thanking Dr. Sajjan sir for giving me the opportunity. So as sir has emphasized, I'm going to be covering the hidden EGFR threats and the role of amivantamab in the context of the exon 20 insertion mutations. So as we all know, non-small cell lung cancer, it is a heterogeneous disease, and EGFR mutations are the most prevalent actionable driver mutation in non-small cell lung cancer. It is found in as high as 35% of patients, and there are different type of these mutations. Next slide, please. So the most common one are the exon 19 deletion, which are found in 44 to 47% patients. The other most common is the point mutation on exon 21, which is the L858R mutation. It is found in around 32 to 45% patients. And we all know these are the good driver mutations. These mutations encode the part of the tyrosine kinase domain around the ATP binding pocket. And these sensitize against the EGFR TKIs. However, exon 20 insertion mutation is another uncommon mutation found in around 1 to 20% patients. Next slide, please. So unlike the mutation in EGFR exon 18, 19, or 21, the exon 20 mutations are typically resistant to EGFR TKI therapy. Why does it occur? Because the common mutations, they cause conformational changes which confer sensitivity to the EGFR TKI, whereas the mutations in the exon 20 insertion subset, they reduce the TKI binding. So, and they lock the molecule in the active state. There is a lower response rate of around 3 to 8% with the conventional EGFR TKI agents. Next. So the in-frame insertion in exon 20 of EGFR genes were actually among the first EGFR mutation to be identified as oncogenic driver. And these, as stated, they account for up to 12% in the EGFR mutated non-small cell lung cancer. So the real world frequency of these insertion mutation varies according to the geographical region. In US and Europe, it is to the tune of 5 to 12%. In Latin American region, around 5 to 8% of the all EGFR mutated population. And in the Asia Pacific, it is found in around 1 to 5% of EGFR mutated non-small cell lung cancer. So the mutation itself, it is in the tyrosine kinase domain, and most insertions typically occur between the amino acid 761 to 775. There are different unique insertions that can be seen. They could be in the helical region or near loop or far loop region. And these are in-frame insertion or duplications. Most insertion are around 3 to 21 nucleotide base pairs, and the location can influence the drug and the ATP binding kinetics. So there is a broad number of these variants, and to date around 100 unique variants have been identified. And there are two most common mutations that have been seen, can be caught by the common PCR assays. So these insertions are unique and distinct from the common EGFR mutation. Compared with the common mutations, these induce conformational changes which reduce the drug binding pocket and affinity for TKIs. So with the common EGFR mutation, there is a reduced affinity for the ATP, and there is an enhanced affinity for the EGFR TKIs, hence rendering it sensitive to the EGFR TKI with a wide therapeutic window. Whereas with EGFR 20 insertion, here it is sterically hindering the drug binding pocket of the TKI molecule, and the activation of EGFR occurs without reducing the ATP affinity, and also there is no reduction in the, there is no enhanced affinity of the EGFR TKIs, and hence it is resistant to most EGFR TKIs with the loss of the therapeutic window. So as we all know, in the two most common mutations, the overall response rates are very good. It is to the tune of 65 to 67%. And the EGFR TKIs have transformed the treatment landscape for the EGFR mutated non-small cell lung cancer, whereas exon 20 insertion, they are resistant to the EGFR TKI treatment, and the response rates are pretty dismal. They range from 0 to 20% in most studies. So the prognostic impact, literature review of 78 studies which are available for EGFR TKI has shown us the response rate, as I mentioned, is to the tune of 0 to 20%. And this is reflected in the median overall survival, which is for this population around 4.8 to 19 months, compared to the classic EGFR mutation where it is 19 to 27 months. And the progression-free survival is even more dismal. It is around 1.5 to 3 months. As compared to the classic mutations where it is 8.5 to 15 months. So the standard of care first-line treatment for this subset is the platinum-based therapies, which will give us a progression-free survival of around 6.6 months and an overall survival of 17 months. In this population, TKI will only give us a progression-free survival of 3 months. Even immunotherapy molecules have given us a progression-free survival of 3 months. And the number for the overall survival is also pretty low. And once we have exhausted the first line, the standard platinum doublet chemotherapy, there is no standard of care so far. With immunotherapy or chemotherapy, both have very limited efficacy, even if we give alone or in combination. So in the second line, platinum-based therapy have been tried, which give us a PFS of around 5 months, and the overall survival is around 14 months. TKIs again are disappointing results, 2.5 months of PFS, overall survival of around 14 months. Immunotherapy again gives us 2.5 months. Immunotherapy overall survival is around 9 months. So this is the real world analysis where they had around 3,000 patients of advanced EGFR mutated non-small cell lung cancer, where they analyzed overall common EGFR mutation results. This is the Flatiron database, and this had around 180 patients of exon 20 insertion, and the median overall survival for the exon 20 insertion was only 16 months, which compared to the 25 months with the common EGFR mutation was disappointing. There was a 75% increased risk of death. The progression-free survival, as we saw with exon 20 insertion with TKI therapies, even less than 3 months, it is 2.9 versus the 10.5, which we see across different EGFR TKIs. There is a around 170% increased risk of progression or death with the EGFR TKIs. The 5-year survival for the overall EGFR population, it is around 19%. For the exon 20 insertion, it is dismal, it is around 8%. So to summarize, patients with EGFR 20 insertion have a poorer prognosis. There is a 75% increased risk of death. The 5-year overall survival, as I mentioned, is only 8%. And these patients do not benefit from TKIs. There is a 170% increased risk of death and progression. Platinum-based therapies are the only therapy that we have had so far, which are the standard of care for the first-line treatment. However, there is no established clear standard of care in the second line. And these poor outcomes, they emphasize that there is an unmet need and requirement for newer and effective therapies. Coming to the Indian scenarios, there is a lack of data. There are only 2 retrospective studies which have evaluated the efficacy of the currently available treatment regimes in this subset of patients. And one of these retrospective studies found out that the median progression-free survival was only 6 months, and the overall survival was around 15 months. And when these patients were given TKIs, the progression-free survival was only 1.9 months. Another study from Tata has shown that the median overall survival, this had even a poor number for overall survival itself, the number was only 5 months. So the prognosis in the Indian context also remains poor. And the prevalence of the exon 20 mutations in India across different studies has been found to the range of 1 to 8%. Here, I would also like to bring up that the PCR-based test, because of the very nature of the PCR test, they are mutation specific and they can only identify up to 5 different types of EGFR exon 20 insertion. Whereas next generation sequencing, we can identify more than 70 different unique exon 20 insertion mutations, and the NCCN recommends the use of NGS-based strategies for the detection of this particular mutation subset. Coming to the molecule in question, the role of amivantamab. So it is a monoclonal antibody, which is a fully human antibody against the EGFR MET. It is a bispecific antibody. It binds to EGFR and MET with a high affinity. So the binding site of this is unique in the sense that it binds extracellularly, so it is not affected by the co-mutations in the binding pocket. As we saw that the intracellular domain, the TKI binding pocket is blocked by the insertion. So this molecule circumvents that inability and it binds to the extracellular domain. And not only it binds to the EGFR, it binds to the MET also, and thus it addresses the 2 major mechanisms of resistance to this standard of care therapy. So there are 3 mechanisms of action for this molecule. One is the immune cell directed activity, the second is the receptor degradation, and third is the inhibition of the ligand binding. So the immune cell directing activity, the ADCC, this is a common mechanism of action for the monoclonal antibodies. Here the molecule binds to the receptor and the FC portion of the immunoglobulin recruits the immune effector cells, the macrophages and the new natural killer cells, and the tumor cell lysis occurs once they are recruited. The second mechanism is the receptor degradation. So once amivantamab binds to the EGFR and MET receptors, there is a degradation of the receptors by the tumor cells, and this leads to receptor inactivation. The third mechanism is the inhibition of ligand binding. So by its very nature, it is binding to the extracellular domain. So the natural ligands for these molecules are blocked by these antibodies, and thus the downstream signaling is also inhibited. So this is administered intravenously every week, initially for 4 weeks, and then subsequently every 2 weeks. The dose for less than 80 kg patient is 1050 milligram. Due to initially there is around 2/3 patient will develop some form of immune infusion related reaction, and because of the high frequency, it is recommended to use a peripheral line for the first couple of weeks, and subsequently a central line can be used. And the first dose dilution should be done as late as possible. So the initial, the dose is 1050 mg per dose per week, initial 4 weeks. And we start at a lower rate of infusion as we do with most of the monoclonal antibody to prevent the infusion related events. So the data for the clinical efficacy and safety comes from the Chrysalis study for this molecule, which was a phase 1 study. So the trial design was pretty standard. The part 1 was to establish the recommended phase 2 dose, and part 2 was the safety and efficacy at this dose. Cohort D was the subset that was dealing with the EGFR exon 20 insertion subset. So this included patients of metastatic unresectable non-small cell lung cancer with this mutation who had progressed on the platinum-based chemotherapy. So this was a second-line study. The key objectives of the dose expansion part was to assess the safety and efficacy. So efficacy primary endpoint was overall response rate, and the secondary endpoints were clinical benefit rate, duration of response, progression-free survival, and overall survival. So the median age in this population was 62 years. Around 60% patients were females. Around 50% patients were smokers. 22% patients had a brain metastasis. Median time from initial diagnosis was 17 months. And most patients had 2 or more lines of therapy. By definition, all the patients were progressing on platinum-based chemotherapy. Around 46% patients had received immunotherapy, 25% had received an EGFR TKI, and one patient was post-posiotinib progression. So the most common side effects were consistent with the EGFR and MET inhibition. So the EGFR related side effects, the common ones, the rash, paronychia, stomatitis, pruritus were seen. Only 4% patient had a grade 3 or higher event. MET related hypoalbuminemia, peripheral edema was seen. The commonest side effect was infusion related reaction, which was present in 2/3 patients, but only 3% patient had a grade 3 or a higher event. Other side effects like nausea, dyspnea, fatigue, constipation were pretty manageable. So around 13% patient had dose-related reductions, and around 4% patient had to discontinue treatment due to the side effects. So the efficacy analysis, the overall response rate was 40%. And out of this, 4% patient had a complete response, 36% had a partial response. Stable disease was observed in 48% patient, giving us a clinical benefit rate of 74%. And duration of response was 11.1%. As the forest plot shows us, the results were present across the age, gender, race, performance status, smoking history, brain metastasis. Patient who had received immunotherapy had around 46% overall response rate, and patient who had EGFR TKI exposed also had an overall response rate of 50%. So the spider plot analysis for the 80 patients in the dose expansion arm shows us that the patients out of 32, 20 patients, 63% patient had a response which lasted more than 6 months. Median progression-free survival was 8.3 months, and median overall survival was 22.8 months, which is an improvement in this set of patients. So efficacy across the different heterogeneous types of exon 20 insertion was seen. It was seen that all kind of mutations had responded to this therapy. To summarize, this safety profile was tolerable. There was a robust efficacy response rate of 44%, median duration of response 11 months, and PFS of 8.3, and median overall survival of 22.8 months. So this is the first bispecific antibody to demonstrate meaningful efficacy in this subset of patients, and this could target other EGFR MET-driven tumors as monotherapy or combination, and it is being evaluated in the other arms of the Chrysalis study. Since this was a phase 1 trial, so there was no comparator arm in the trial itself, but there was a protocol-driven external treatment comparison comparing it to the databases that are available for this subset of patients. So 3 databases were consulted: the CONCERT, COTA, and Flatiron. So the populations were comparable in terms of the age, gender, race, smoking history, brain metastasis, and the prior line of exposure. So here we can clearly see that the standard of care therapy gives us around 13 to 18% overall response rates, whereas 40% was observed, which is a marked improvement. And the progression-free survival, the pooled real-world survival progression-free was 2.9 months, whereas in this study it was 8.3 months. The time to next treatment was also improved from 4.8 months in the real world with other therapies. It was 14.8 months, which is a 10 months improvement. And so was the overall survival, which was from 12.8 months. There was an improvement of 10 months to 22.8 months. So the most commonly used real-world treatments included non-platinum-based therapy, immuno-oncology therapies, TKIs, and platinum-containing therapies. And we observed that the overall survival was 10 months longer, and there were corresponding improvements in other outcomes in terms of response rates, progression-free survival, and time to next treatment. And this shows that also re-emphasizes that there is a relative ineffectiveness of currently available real-world treatments. Thank you very much for your time and attention.
Thank you, Dr. Vidushi, for this very extensive presentation on this subset of patients. So, what do you feel about this drug? Like, do you still feel that this is unmet need? Still, we need more better drugs, or you feel it's just a prototype, or you're happy? What is your experience with any of the patients where you use this drug?
In the past, the EGFR exon 20 insertion subset is the dreaded subset of the EGFR family. So, and I've seen none of the therapies working. Under your guidance only, we have started therapy for a couple of patients, and so far they are doing well. But we'll have the data is pretty strong, but we'll have to see over time how it fares. And there are a couple other molecules. Another molecule, mobocertinib, is also now FDA approved. And poziotinib, this is under consideration, not yet approved. So we'll have to see how they compare against this therapy.
So I think infusion-related reactions might become an important hindrance to this drug. And we need to understand that various drugs, we have always had this desensitization protocols, and here also we need to be very careful, because almost more than 50% of patients will require some form of care with the infusion. So I think that is one thing where the clinicians will have to be careful when we use this drug. Otherwise, should be a good drug, and there are not any major side effects apart from this infusion reaction which can happen.
Absolutely.
Dr. Aditya, Dr. Aditya Sareen, have you used this drug in your practice at Gangaram Hospital?
Hi, sir. Good evening. And sorry, I'm not able to switch on the video. I'm currently in the traffic right now. I'm going back.
And Dr. Jyoti, have you used this drug in any of your patients?
No, sir, not right now. Good evening, sir.
Good evening. Yeah. So I think because this is going to be a niche indication, and the important thing which we have to remember is that we might get patients who are post EGFR progression more than upfront mutations in this exon 20 or 20 insertion. And one more thing I think Dr. Aditya Vidushi mentioned very rightly was that normally when we are getting these tests which are hotspot panels, which are just PCR based, we might actually miss out on many of these exon 20 insertions. I think that is where we need to be careful, especially with the subset patient who might benefit. I think this will be a message for today evening. And Dr. Rajat has joined us.
Can I comment one thing?
Dr. Rajat, can you hear me? I think Dr. Rajat, are you able to hear me?
Hello, sir. Yes, I can. Sir, good evening.
Okay, so good evening. Are you traveling, or you have reached somewhere?
No, sir. I've stopped myself from traveling till the time I finish. Then I'll travel.
Thank you so much. I think life has made us all busy, and we all are juggling between our professional and personal life. So I'll just introduce the panel, and then I'll introduce you. So we have a very eminent panel today. And again, this session is being sponsored by AstraZeneca. And it is actually a case-based panel discussion, which will cover the same scenario which we have been discussing: EGFR mutation, non-small cell lung cancer, how to approach a patient, and what are the second line, third line options, what are the kind of mutations which can happen. So I think the various scenario will be discussed by our moderator. We have Dr. Jyoti Anand, concerned medical oncologist, Dr. Aditya Sareen. We also have Dr. Aditya Vidushi in the panel. Dr. Amit Sherawat has network issues and he's not able to join. I just spoke to him right now. And Dr. Amit Verma was supposed to be here, but I think he had the first talk and he had some urgency, he had to leave. Rajat, you can also consider me as one of your panelists, and I'll be also part of the panels. So I'll introduce you to Dr. Rajat Bajaj. He is a good friend and a very eminent speaker and a moderator. And over to Dr. Rajat for the panel discussion.
Thank you, sir. Good evening, everyone. I thank you for your kind words, and thank you for having me here, and thank AstraZeneca for giving me this opportunity. So we will now go on to the panel discussion about the advanced EGFR mutated non-small cell lung cancer. Can I have the next slide, please? So I think my esteemed panelists, all of them are there. Dr. Jyoti, Dr. Vidushi, Dr. Aditya Sareen, and Dr. Sajjan is of course there. So I'm sure all my panelists will agree that we have discussed this many times. What do we do in EGFR mutated NSCLC? So there are few things which still need to be discussed because there are certain gray areas here, and all of us as medical oncologists in our practice do a little different when there are gray areas. So as we if we really go about sharing our clinical experiences, it will be good for us to treat our patients with a collective effort. So these are the different case scenarios that we'll be discussing in this panel discussion in the next half an hour or so. So coming to the first case, please, can we have the next slide? This is an EGFR mutated patient, and the case says that a 65-year-old man, non-smoker, comes to us with complaints of cough and pleuritic chest pain. A CT scan is done. There is, let us consider this as a PET scan. Left lower lobe mass 5.5 centimeter. It invades the pleura. There is a left pleural thickening, which is avid, is what I will give it to my panelists. And there is a left hilar lymph node. Right paratracheal lymph node is also there. And the diagnosis of adenocarcinoma is confirmed on biopsy, which is TTF1 positive, and napsin is also positive. So Dr. Jyoti, hi, I start with you. If your pathologist says that TTF1 and napsin both are positive versus only a TTF1 being positive, does that make a difference to you?
As long as it is adenocarcinoma TTF1 positive, I don't think, and we have already an oncogenic driver mutation positive, so it doesn't probably make a difference for me.
Okay. No, so we are not talking about the EGFR mutated NSCLC as of now. I'm just talking about the adenocarcinoma where there are two markers positive versus only a TTF1 positive. Dr. Vidushi, do you think that two markers positive, any difference in prognosis, good prognostic, bad prognostic, anything?
So as long as the like the other clinical details are the same, I think I would probably treat them the same.
Okay. Of course, the treatment doesn't differ is something which is absolutely correct. Okay, so the oncogenic driver mutation testing was done, and EGFR was exon 19 deletion positive by ARMS PCR, and PDL1 expression was also done, which was 95%, is what is written on the screen. So Dr. Aditya Sareen is with us. Dr. Sareen, do you think that this is how you go about doing your molecular testing as well? If you have to do an EGFR, what are you resorting to? Are you doing an ARMS PCR or are you doing an NGS, and reasons for the same?
So, well, right now I am where I'm practicing. So I am using NGS, and because of, I don't have right now in-house availability for, EGFR by IHC, or so all the technology is not yet here with me. But yeah, I am comfortable with the NGS hotspot panel, and that covers most of the things that I want to look at.
Okay, so if we talk about the oncogenic driver mutation testing, and if we talk about the NGS, so if you have a patient who is having this currently a PET scan where there is the only site of metastasis looks to be pleura, and this becomes a stage 4A, what would you like to start this patient on? And you've sent the EGFR, and since you said that EGFR is being sent by NGS, I'm sure the turnaround time must be more than 2 weeks. So do you start the patient on treatment, or do you wait for the EGFR NGS report to come in?
So in my practice, so what I do is I start usually with the chemotherapy, and for me the TAT turnaround time is somewhere around 10 days to sometimes they do give it me in 8 or 9 days as well. By that time, my chemotherapy is good enough for them, and it is good there for another 3 weeks. So by that time, he's due for the next cycle, and in between that, I get that report. So we just explain the patient that we are switching on you to this driver mutation. So for the timing, I have this kind of an institutional practice at the moment.
Okay, and are you also doing PDL1 at the same time?
Yeah, even at the same time. Yeah, absolutely. But I'm using but I'm sending it while, the sample has been sent for NGS. It's in concordance with that only.
Okay, okay. So the patient is asymptomatic and still we start with chemotherapy. Dr. Sajjan, sir, do you think that in your practice, this is what you are doing? One is the question about whether we send the NGS first or the ARMS PCR. Second is starting of chemotherapy if the patient is symptomatic versus asymptomatic. And the third is, are we doing PD-L1 expression in a patient who's a non-smoker along with NGS, or are we waiting for the NGS report to come and then PD-L1?
Okay, so I think very valid points, Dr. Bajaj. So first thing is very important that the clinical scenario, especially with a non-smoker, and if the patient is asymptomatic, so I would mostly wait. But then what happens is normally such patients are difficult to get in a clinical practice, because in our practice, many times when patients come, they would have some symptoms. So what I end up doing is, again, I would agree with Aditya that we start with at least a single agent platinum or a doublet based upon the symptomatic nature of the patient. So first dose of platinum based either singlet or doublet is given to the patient. And again, depending upon the financial condition of the patient, because sometimes we understand that patient might not be able to afford drugs which are beyond a certain limit of the capital. So based upon that also, it is very important for me to decide, because if I feel that drug might not be available or best drug might not be available, then I prefer to go for chemotherapy and then go for either a hotspot panel based upon the patient's finances, or if possible or given a choice, I'll go for a more extensive genomic panel, and also simultaneously send for PD-L1. So I am happier to get all the information if logistics are not an issue. If logistics are issue, go for a selected panel, and based upon the symptomatology, either no treatment, wait for some time, or give a singlet or a doublet based upon the patient characteristics.
So if the patient is asymptomatic, like this patient is, because there is only growth thickening, we can wait. This is what you're saying?
Yes, yes,
okay.
Yes.
Okay, agree. And also you are doing NGS for all the patients. You are not doing a individual EGFR or ALK for the want of having the test in a shorter span of time.
So as I mentioned you, for some patients I get it. I don't go for comprehensive gene panel, especially if the finances are an issue. But if finances are not an issue, then I would love to have a more comprehensive coverage, because in the last like in the first part of this meeting, we have discussions from the molecular oncologists that almost 30% of patients will actually miss mutations, especially only go for hotspot or focused or multiplex PCR based test. We might actually miss out on opportunities to treat them. So given a choice, I am more happier to go for a more extensive genetic profile, and also as well as PD-L1.
Okay, Dr. Jyoti, so PD-L1 expression, are you doing it along with either an NGS or an ARMS PCR, whatever you're going for, or do you wait for the report to come in, because he's a non-smoker? Probably if he comes out to be a driver mutation positive, PD-L1 may not be required. Is this what you're doing, or are you sending a PD-L1 also upfront?
I think we all are using that 12-gene panel, which includes PD-L1. So most of the times PD-L1 is being sent along with NGS. So we get the results simultaneously.
Okay, Dr. Vidushi, I prefer to do EGFR by ARMS PCR because the report comes in 3 days. I did an ARMS PCR, it came out to be positive exon 19 deletion. I told the patient that there are few options of EGFR based therapy for NSCLC, and I gave him 1 or 2 options, but he says that I would want to consult Dr. Vidushi once again. So he comes with a report to you, EGFR is mutated, it is a metastatic NSCLC. Would you like to tell this patient for an NGS?
So as long as the PCR is positive, it is showing a driver mutation positive. PCR is fairly sensitive, and I'm not looking for any more targets as such. I would want to start the TKI therapy at this point.
Okay, so you start the therapy for sure, and probably your preferred regimen can be possibly osimertinib or 1 or 2 more. We'll talk about that. But then, despite starting this therapy, would you like to get an NGS done?
Yes, sir. Like I would not wait for the result, but yes, a broader panel including all the other driver mutations. I would want to know the PD-L1 status.
Why?
Sometimes, sir, they could be coexistent mutations. Like EGFR ALK has been known to coexist sometimes, rarely, but I would want to know so that in future, if my patient is not responding to the EGFR TKI therapy, if I start osimertinib and they are not responding, so I would want to know the status of other mutations.
But then why PDL1? Hello.
Yes, sir.
Okay, we come to Dr. Sareen. Dr. Sareen.
Yes.
Yes.
Dr. Sareen, do you think that NGS is still required if an ARMS PCR is positive and you are planning to start the patient on XYZ any therapy against the EGFR positive status? NGS is still required, yes or no?
Well, I'll be very honest. I haven't been inquired. I really don't know the answer to that question. I haven't experienced that way. For me,
Okay.
because my standard of the practice is straight away go with NGS. So I have to check the literature on that.
Okay. Dr. Sajjan, we come to you, final word. So NGS is still required, yes or no?
So if you found a driver mutation on PCR, I think you can wait. You can start with the drug and wait for the drug to act. If the drug does not act well, you have an early failure, then you can again go for more CGP kind of a panel. It is also possible that the patient comes to you from outside and they would like to inquire for him, like you said, a person comes to you for a second opinion. Again, you can tell them that this is possible. The time period actually is based upon the patient's preference as well as your own preference. I think either ways it would be right if you have one proper actionable driver mutation in your hand.
Okay, but then one thing is for sure that PDL1 is not required in this patient.
So again, PDL1 might add value in the second or third line. Right now, it will not add any value. So having a PDL1 because again it's mostly a ISC based test. It could just tell you as what is the level of PDL1 expression.
My intention to send PDL1 upfront is only one, that if my NGS turns out to be negative, then I don't want to wait for another 5-7 days to get that PDL1 report come down later. So that is only the way I'm doing it as a reflex test in order to make sure that the patient receives the right treatment at the right time and he doesn't have to wait for a longer period.
But if we have a case PCR discrepancy, I would still want to go with the PCR result because that I feel is the more sensitive.
So this is a little controversial statement then. So basically, basically the thing is that I think Dr. Sajjan very rightly put it. We would like to still get an NGS done for sure, and the reasons for that is that
I have a suggestion.
Hello. Yes.
I'm Dr. Amit here.
Yes, sir. Please go ahead.
So
I was told you are not a. We like to have you. Please go ahead.
No. So basically, once the EGFR is there, definitely you have the therapeutic option ready. Whatever you choose, whether it's second generation or third generation, it's a preference. But if somebody wants to know beyond this, let's say patient wants to know the prognostication, how will they behave overall? What will be the duration of response? How long the benefit will be given to the patient? In that case, getting the NGS will be very, very prudent. We understand that EGFR is fair enough, but the downstream that is KRAS is a non-mutually exclusive alteration with EGFR. And we know it is a prognosticating marker and also a poor marker to response to EGFR TKI. So this is one possibility which can be seen in 1/4 time of the cases actually whenever you do the NGS test actually. And top of it, there are less than 5% chances, maybe less than that you may end up having co-mutations which may have implications in your treatment outcomes actually.
Okay, agree. So this is what I was looking for, and we always had to fall back on the molecular oncologist to tell us that absolutely correct. We have coexisting mutations. We can have mutations in the downstream signaling pathway for where we would have to prognosticate the patient that the PFS is not going to be as bright as 18 to 20 months, and it can be much shorter than that. Also, there has been a recent paper in the Translation Lung Cancer Research journal where I think last year where it was said that even in exon 19, if you have a deletion of the base pair 746 to 750, these people are doing much better than if the deletion starts from 747 base pair. So there is a lot to do in terms of the deeper innuendos, and that is why NGS is still required. But of course, as I said, NGS has got its own perils because the turnaround time is not as good. Also, we would have loved to talk about the DNA and the RNA based NGS testing and fusions, how we really detect, but then it is beyond the scope of the EGFR mutated NSCLC that we are discussing. So we move on. Next slide, please. So the PDL1 we've discussed how do we really wait for the EGFR report. So also our panelists have already told that if the PDL1 is high, even if it is high, they would like to start the patient on EGFR based therapy and not really start the patient on immunotherapy. This is what we have discussed. Next slide, please. So Dr. Amit, the question to you, if we talk about the EGFR testing, do you really resort to liquid biopsies also? Because the liquid biopsies, the report is going to come in a day or two, and if the patient is positive, we can start the patient on therapy. So are you doing that in your practice for EGFR, for finding out the EGFR status upfront we are talking about? And having said that, I would like to point out that it is approved by NCCN and we can do liquid biopsies with a high concordance.
Certainly, when the biopsy is not visible or tissue is limited, liquid biopsy is my first choice. And beyond the EGFR, it can detect the other alterations which are relevant alterations. So certainly it is my choice when the tissue is not feasible.
Okay, right. Next slide, please.
Dr. Rajat, I'd just like to add, I think I'd like to ask Dr. Amit. So is there some data which shows that patients who have got actionable driver mutation along with high PDL1 positive, are they likely to do worse compared to people who have got no PDL expression?
So the answer is I would just like.
Sorry.
Yeah, sir. Please go ahead.
So
this is very independent. This is a very independent thing. So normally PDL1 expression gives you a prediction that the patient have some immunosuppressive phenotype, and these patients carry poor prognosis. Over the higher the PDL1 expression, poorer is the outcome. It's a generic phenomena. But at the same time, higher the PDL1 expression, you have a therapeutic target. But whenever it comes along with the EGFR, PDL1, there is not much of association seen. And you cannot predict the response to TKI just by the PDL1 expression, what is going to be the implications. But on the other hand, whenever you have alterations like MET alterations, MET amplifications or MET mutations, and whenever you have high PDL1, which is normally seen in the case, you may see a better response to the TKI as compared to the EGFR TKI along with PDL1. So depending upon the context, you may have a different, you can say, correlation actually.
Agree. So EGFR and PDL1 status, they don't really hamper us giving us the anti-EGFR therapy, and any PDL1 status, the response is going to be the same. And this is what is shown in the on the screen right now. And this is the data of evaluation of more than 100 patients from the FLORA study. Irrespective of PDL1, the curves, they are separating widely in favor of osimertinib, which was the experimental arm in this particular trial, as we all know. Next slide.
Can I say something? I think it's not only MET, but I think if the KRAS is also present, it's going to be a strong supporter of PDL1 therapy.
Agree, but yes, agree. Very rightly put. Both KRAS as well as MET, but both of them are going to have a high PDL1 status, and the patient is going to do well on the inhibitor therapy. Yes, agreed. And we already know that if the patient has got a EGFR mutation status positive, the immunotherapy doesn't work, and this is the data in support of that particular statement that we all know, that immunotherapy doesn't really do wonders if the patient is having a EGFR mutated status. In the first line at least. Second line, of course, we have the data from the atezolizumab study, but in the first line, the single agent immunotherapy is just a no-no for such patients. Next slide. Next slide, please. Yeah, so talking about oligoprogression now. Next slide. So Dr. Aditya Vidushi, I start with you. You have a patient who's being treated with a EGF with osimertinib, who's an EGFR exon 19 deletion mutation patient. There has been a good response. There has been a progression-free survival of about 18 months already, and now you see that there are 2 new metastatic bone lesions which have come up. So what do you really do about these patients in your practice?
So if it is a limited progression, we can think of local therapies. We can think of local radiation, treating the local progression and continuing with the systemic therapy.
Systemic therapy, which means osimertinib?
Yes.
Continuing with osimertinib?
Yes,
Okay.
and
Or
adding
adding
the
something.
local therapy for the newer lesions if it is a limited progression.
Okay, or adding nothing to osimertinib, continuing only with osimertinib. Okay, right. Dr. Sareen, what do you think? Such a scenario, if you come across, what would you do?
Well, to be very honest, if we are talking about an oligoprogression, I would like to, continue the original drug which I was using, which is osimertinib in this case. And with the appearance of two, new lesions, I would like to get them biopsied. But having said that, if they are, easily biopsiable, if you have a visceral met, a very simple looking, or you can biopsy it very easily. Not the bone metastasis I'm talking about, but if the lesion is biopsied, if I can do a biopsy, I would like to do the biopsy and send it for a repeat NGS. So that is one take. And if that scenario is not there, then I would like to go for straight away SBRT to the local lesions that I'm seeing on the scan.
Okay, so if you get do a repeat NGS and comes out to be a MET amplification, then what would you do?
Well, I think then I will have to still squeeze out more osimertinib and keep on taking the benefit till it really converts it into a progressive stage. And then finally, once it's really progression, and I can't really say it is oligoprogression. I have to say it is really progressive disease. Only and only then I will switch on to the MET inhibitors.
Okay. So Dr. Jyoti, if this question was asked, for a patient who has already had a PFS of 24 months on osimertinib and 2 now new metastatic bone lesions versus a patient who is having a PFS of only 10 months and then new metastatic bone lesions, does that really make a difference for you?
I don't think, Dr. Rajat, that makes a difference for me, because now we are talking about, be it the PFS of 2 years, be it the PFS of 10 months, we are talking about oligoprogression. So my plan will remain the same. Yes, we can do biopsy, but again, in oligoprogression, it is very difficult to change the drug. So I would like to continue with osimertinib, maybe adding bisphosphonate and managing the local site with local therapies like radiation and if some visceral metastasis, if surgery is possible, like that.
Okay, so if the patient has already completed 24 months and now you've given SBRT and you're continuing with osimertinib, when will you do the next scan?
3 months.
3 months. Okay, Dr. Sajjan, sir, what do you think? How do you handle such patients?
Yes. So normally my scans to begin with obviously are at 3 months interval, but then once I feel that the person is responding well and there are no symptomatic progression, then I tend to get scans at 6 months if the patient is asymptomatic.
So at the PFS of 24 months already done, 2 new bone metastatic lesions, SBRT done, next scan will be?
You're talking about oligoprogressive disease. Disease has progressed.
Yes.
Yeah, then I think I have to be very careful because once we are trying to understand whether this is actually truly oligoprogressive disease or there's actually the kind of a tumor heterogeneity which is causing these lesions to come up. I think our first follow-up scan should be at 3 months. And if at 3 months also there is no disease, then again, we can be assured that there was a kind of oligoprogressive disease.
Okay, so yeah, so the message very rightly put that if you have a patient whose PFS has already been over, we have a median PFS about 18 to 20 months, we should be really more careful about these patients because there can be a scan bias, and the patient, when the scan was done, only had two bone lesions which were targeted by local ablative therapy, but then for all after some time the patient may throw up some other lesion or more lesions than that. Okay, right, next slide please. So anyone who has got an experience of giving any targeted therapy post osimertinib? I'm talking about full-blown progression post osimertinib. Any targeted therapy given, any clinical trial? The question to all the panelists, or everybody has used chemotherapy after osimertinib. Anyone who has had the experience of giving savolitinib according to the TATON study, of course, which is ongoing, or a combination of Erlo plus osimertinib if we have a C797S. Anyone?
Not yet.
Okay.
So we have used this amivantamab actually post osimertinib. That is
post
one.
Second line. Is it second line?
Second line, yeah. And also the experience was not that great at all. The patient still progressed, and because it was under the trial setting, and the selection of the patient was not based on the biomarker. So it is assumed that the post-osimertinib, it is because of the MET alteration, amplification, but that is an assumption. So it is a possibility that the patient might not have the MET amplification of the resistance mechanism for osimertinib failure.
Yeah, so which trial are we talking about? Second line amivantamab post-osimertinib?
So this was the trial which was
Astra trial has, it's one of the Astra even asked as that.
Yes.
Once the
I think if I remember it, Rajiv Gandhi was doing this trial, osimertinib post osimertinib progression actually.
No, but then that is the Chrysalis study where it is osimertinib followed by platinum-based chemotherapy, and then all comers received amivantamab plus lazertinib. So I am not aware of any study where all comers are receiving amivantamab.
Rajat, there was a trial where there was a failure of EGFR TKI first line, and the reason for failure was exon 20 insertion. So in that setting, I think there was a trial.
Of course. So that's what I wanted to ask. Okay. So in that case, of course, but in all comers post osimertinib giving
not in all comers. Not in all comers.
Okay. Agree. Exon 20 insertion mutation amivantamab. Agree. Right. So I think most of us are giving chemotherapy post osimertinib, although there is good data to suggest that we should do an NGS post-free biopsy and look for what are the resistance mechanisms, because the resistance mechanisms post osimertinib are not the same as they are for the first generation, the second generation TKIs. We have the most common resistance mechanism as the MET amplification, about 18 to 20% patients. Then we have the C797S mutation, both cis and trans. We also have the histological transformation to small cell, or for that matter a HER2 or a PIK3 mutation. Very rarely you can have an exon 20 insertion mutation, as Dr. Sajjan also very rightly said. And also all of us do know, and we are aware of the Chrysalis 2 data which was presented in ASCO 2022 recently post osimertinib and platinum based chemotherapy. The all comers data of lazertinib plus amivantamab, which has shown to have a clinical benefit in excess of 50%. But then of course this drug lazertinib is not available in our country. Amivantamab is something which is not easily affordable for our patients. This still remains a experimental therapy as of now.
One more thing which I like to add is that there's some benefit. There's some benefit in MET amplification also with amivantamab. So I think that was the reason why probably some patients were put on, because that is one of the important mechanisms of secondary resistance to osimertinib.
Agree. Right. Anyone who has used twice the dose of osimertinib, 160 milligrams of osimertinib. Anyone? Dr. Vidushi was talking about exon 20 insertions in her talk. There are case series of using osimertinib 160 mg in exon 20 insertion mutations if the patient cannot afford amivantamab or mobocertinib. There are case reports of patients being on osimertinib 160 milligrams for leptomeningeal disease, or for that matter leptomeningeal disease plus brain parenchymal mets. So anybody has that experience of 160 milligrams of osimertinib? Anyone? So I have had two patients. I have had two patients where I have used osimertinib 160 milligrams in leptomeningeal disease, one, and the other in patient having brain mets plus leptomeningeal disease. After doubling the dose of osimertinib, I could have and these patients, they had a relatively well controlled extracranial disease. The one was a young lady around 35-year-old, and the other was a 65-70-year-old lady. Both of them classical non-smoker female patients. So both of them had a PFS after doubling of the dose of somewhere around 6 to 7 months, which was was not really bad, because leptomeningeal disease is a bad disease, we all know. So but this is
And
of
what
course
about
something
the
which is not.
adverse events? Were there any while you double your dose?
No adverse events reported, and it was a very well tolerated therapy. Even there was no diarrhea, very well tolerated therapy. But of course, there were patients who had the reimbursement done from the government panel, so they could afford it. Otherwise, it becomes very costly. So
That's something new. I mean, it is really one of the most peculiar thing that doing 80 to 160 mg. I'll be very happy if it was. I'll definitely try.
So and that too, giving a PFS of about 5 months to such patients is actually very good, right?
Wow,
So
really?
please, can we have the next slide, please? Yeah, next slide. This we've done. Next slide, please. Next slide. We come to the third scenario now. Next slide. Yeah, so CNS metastasis. So Dr. Sareen, I start with you. If you have a patient who has a CNS metastasis, or rather, we put it the other way. Suppose you have an EGFR mutation positive patient and there is no CNS metastasis. Okay, you have done an MRI of the brain. Do you do MRI brain for all such patients who are EGFR mutated?
Well, I'll be very honest. I do MRI brain for all of the patients for lung cancer.
Okay, great. So you did an MRI of the brain, and this patient did not have any brain metastasis. You've sat with your radiologist, and he has also poked his eyes into all the corners of the MRI brain, and there is no brain metastasis. The patient says that, what are the options in front of me? And you give the option as osimertinib. Your colleague in some other hospital says that if you do not have brain metastasis, you have the option of another therapy which is called erlotinib plus ramucirumab, which has got a higher PFS as compared to osimertinib, which does not go into the brain, but the patient in any case does not have CNS metastasis. So what is your take on it? Would you still like to start with osimertinib, or do you have the option of giving an erlo plus bev or an erlo plus ramucirumab combination according to the Relay trial?
So I haven't used the data as per the Relay trial, and somehow I have always been very comfortable with osimertinib. So I'll stick my guns to osimertinib right now.
Okay, Dr. Jyoti, erlo plus ramucirumab in patients who does not have a CNS metastasis versus osimertinib in a patient who does not have CNS metastasis. So can we do both? Is it something that is clearly a writing on the wall? The PFS is in favor of erlo plus ramucirumab, although these are cross-trial comparisons.
But we have data of osimertinib with CNS metastasis. Let us say if patient has no obvious metastasis, but there is disease which is not visible right now. So osimertinib has data of crossing the blood-brain barrier and giving us good CNS rates, control rates as compared to, I think, the other therapy.
Okay, Dr. Vidushi, do you think Dr. Jyoti is absolutely right in saying that as an EGFR mutated patient, one is very wary of the fact that even if the baseline metastasis in brain is not there, these patients are going to develop metastasis in the coming few years. So why not have a drug which is going to prevent or delay the CNS metastasis, and it is very clearly shown in the FLORA study. So do you think that for you also, despite not having a baseline CNS metastasis, osimertinib is the go-to drug?
Absolutely, sir. As long as there are no financial constraints, osimertinib would be my drug of choice for starting treatment in an EGFR mutated patient.
Okay, and your answer is going to be the same even if you are sitting tomorrow in a Lilly symposium?
Yes.
Huh? Okay.
The only time I would make a change or discount would be in a case of a financial constraint where I could consider the Tata regime that has been used, gefitinib and chemo. If the performance status is that good, a chemo doublet and gefitinib therapy. That
you would do that
in a financially constrained patient, not otherwise.
Financially, no. The patient is Ambani's relative is come to no financials.
So absolutely, osimertinib is my molecule of choice. Yes.
Okay. So next slide, please. So this patient was given osimertinib, and next slide, please. This is a patient of CNS metastasis. Horizon people have started to sleep now. Garima?
Deepika, please. Next slide. Gitika, please switch on the mic.
Yeah. So we did this CNS metastasis patient. What I was asking and coming to Dr. Sajjan sir, do you think that in your practice there is any difference between an asymptomatic CNS metastasis or a symptomatic CNS metastasis in an EGFR mutated patient? So for people who are trying to learn from the comments that you will make on this particular point, I want to ask your views on CNS metastasis just being one particular thing for you, or do you think that we should always have a look at the MRI brain films as well to see what is the location, supratent versus infratent, perilesional edema, what is the size of brain metastasis, even if the patient is not having symptoms right now, can develop symptoms in the imminent future? So what is your take on it?
So I think it's a very valid question. So if a patient comes to me with asymptomatic brain mets to begin with, so a de novo patient with brain mets, I'll be okay not treating them for brain directed therapy. I would like to happy to start with osimertinib. But if any of my patient who would on follow-up develop some asymptomatic brain lesion, and that is where I need to be very careful as to which part of the brain that lesion is there. And I could have two options. One is the lesion is really small, like less than 1 centimeter. I could actually see the progression of that lesion over time, how this lesion is progressing. Otherwise, going for a brain-directed RT is my choice on patients who are otherwise asymptomatic on osimertinib, because if a lesion is developing on osimertinib, then I really don't have much choices in my treatment. So I either, like as you said, that either you could try your luck with increasing the dose of osimertinib and see whether how long you can keep them under control, or you could add a local radiation. You could start with SBRT alone to that area and then decide what to do further. So for de novo, yes, I can wait because osimertinib will go to the brain. It will work on that lesion. I could wait for brain-directed therapy. But somebody who develops even an asymptomatic brain lesion on osimertinib, I'm happy to treat them locally.
So I have a question over here. What about the experience of using, doing for a metastatectomy from the brain lesion and followed by using Ommaya reservoir and giving, intrathecal, methotrexate. So I just want to know from the discussion, do we have something like that experience and still continue your osimertinib?
So Aditya, I'd like to answer that question for you, because normally on follow-up, we are not very keen sending our patients to neurosurgeons for surgery, though the guidelines suggest that a surgery should be done for such lesions, and then you could follow up them with either stereotactic radiation and or Ommaya, all those things could be put. But then we tend to have non-invasive local treatments, and I think there's I would say there's an improvement in PFS if we go for 2 local therapies, but then in practice we are not going for that. That's number one. But in de novo patients, many times we are getting patients who have actually been operated for lesions in the brain by the surgeons, and then they have been found to be lung cancer. And I think there is the only area where I found that neurosurgeons are operating. Normally, in my patient, I'm hardly referring my patients for neurosurgery.
So I agree, sir. I think most of the time we are following the same practice, but there is one important thing I think we all are, I don't know, the discordance between the tumor heterogeneity, because only doing, metastatectomy can give us an idea about the tumor heterogeneity, because I would be personally like to send the sample for another, NGS to let us know how this lesion is escaping osimertinib. So, I mean, I want to do that, but then again, you have rightly said that we generally don't refer, and I just wanted to know how common is it.
I think Rajat can add something, because it might be different from what I'm doing. Rajat, how do you do?
No, I agree. I completely agree with what you said. We are not routinely sending our patients to neurosurgeons until unless what I can think. I have not personally come across that scenario, but what I can think is that the patient has been doing very well. There has been a PFS of 2.5-3 months, and there is a new lesion which crops up, and I don't want to stop osimertinib. Then that lesion can be sent to a neurosurgeon, where they will get the histopathology report, as Dr. Sareen is also very clearly pointing out. And we would like to actually know, if from our academic interest also, as to what are the mutations which came up. So, I mean, that can be done. But then apart from that, not routinely we are sending such patients to the neurosurgeons. And no question of Omaha reservoir really, because that is for the left meningeal disease. But then, if we have such a patient, then only that patient can be sent for a neurosurgeon's opinion. Right. So I would like to, ask the final question to all my panelists, and then would close this panel discussion for today. Is that we've all been using osimertinib for years now. What has been any uncommon side effect that has been seen by our panelists, or for that matter, I would like to ask any very common side effect which has been seen, because every now and then we keep on discussing about osimertinib and discussing that there are no side effects of osimertinib, and you have to remember that all the discussion of osimertinib is on a sponsored session, so we really don't go about discussing the side effects of osimertinib, because we think that there are no side effects, but then what are the common side effects which have been seen, and what are the uncommon side effects which have been seen? And I start with Dr. Amit Verma, if he's still there.
I don't think I have come across any important side effects which needs to be mentioned, which we don't know about. But
I think there's some
I
voice
think it
breakage
is a
happening on.
well-tolerable drug. This is my personal opinion of the discussion what we had with the patients, and yeah, Anila can give the comments on that. Yeah.
Okay,
So
Dr.
in my
Jyoti.
practice, okay, not Jyoti first.
Dr. Rajat, I would say fatigue is the most common, which is class-related probably side effect, which my patients suffer the most commonly seen side effect.
What about diarrhea?
Not much encountered.
Not diarrhea. Okay, Dr.
No.
Sareen.
Touch wood, I haven't seen any up till now.
Okay, nice.
I'm a very newcomer to the field. Maybe that's the reason.
Okay, right. Dr. Vidushi.
I've seen a couple of patients developing cardiac arrhythmias. I've had 2 patients who had atrial fibrillation. Other than the regular like EGFR TKS, it is otherwise well tolerated, but 2 patients I've seen who have had to discontinue because of the AF.
And that AF was attributable to osimertinib?
Yes, sir.
Okay. Dr. Sachin, sir, your comments.
So I think I agree with you, Rajat. I think diarrhea has been one disturbing thing with my patients, because there were 2 patients whom I had to actually stop osimertinib because of really severe diarrhea.
Yeah,
and
so that's an important message.
that was really concerning me, and I had to change the drug to another drug. So I ended up giving them Gefnib, because that was the drug which I had to change. And both were elderly people, and I couldn't manage the diarrhea. So that has been, I think, major concern. Rest and many times diarrhea is there, but it's manageable. But then 2 people had diarrhea where I had to really stop the drug.
Okay, agree. Yes, I completely agree. I was actually about wanting to bring about these 2 points, one from Dr. Jyoti and the other from Dr. Sajjan. Dr. Jyoti very correctly pointed out fatigue is there. We would really want to, not listen to these aspects from our patients, because we would always want to have these patients smiling in our OPD, saying that everything is absolutely fine, and we would like to have a feeling that we are winning the situation by giving osimertinib. But then these patients do feel fatigued, and which is there in literature as well. And if we talk about diarrhea, yes, very less talked about as far as the diarrhea aspect is concerned with osimertinib. But I have also had patients, I think 2 or 3, where I've had to stop the therapy, switch to JEF. I've also used a JEF plus osimertinib combination, although of course it's a phase 2 study, JEF and osimertinib alternating days, and there the patient has tolerated the therapy well. There is a patient who's a 92-year-old lady where I'm giving osimertinib, and she had a lot of diarrhea. There was dehydration, and she had to be admitted also. Dr. Jyoti is making faces as to why you are giving osimertinib in 92-year-old lady. So that's how it is. So I think we've discussed the length and breadth of osimertinib, and the people in AstraZeneca will be happy by knowing that osimertinib is a favorite go-to choice for all the panelists, and they don't want to listen to Gefnib plus ramucirumab combination at all. So with this, I thank all my expert panelists for pitching in and giving their expert opinions regarding all the important points of discussion regarding EGFR mutated NSCLC patients. I thank Dr. Sajjan and his team for having me here. I thank AstraZeneca, and with this, I hand it over back to the organizers. Thank you.
Thank you so much, Dr. Rajat Bajaj, and all the esteemed panelists for making this a really interactive panel discussion and keeping the momentum high till the last time. And it's already 9:30, beyond 9:30, and it has been really hearty discussion. And we have actually learned from each other a lot of aspects which we otherwise would not discuss in our practice, and we just go on with the routine proceedings in our OPDs. Also, I think. Certain aspects of osimertinib which we need to be careful have also been highlighted. It has been a very balanced panel discussion. So with this, I like to thank all of you for spending your time in the night and also keeping you away from dinner. And I will also like to look forward to join us again tomorrow for another session on lung cancer. And with this, I like to thank all the panelists and the faculty members for joining us today. I'd also like to thank our sponsors for today's evening meeting, AstraZeneca and J&J, and the organizers. They've always been very forthcoming and helping us out with the timing and scheduling of the meeting so that the meetings don't oversee the time, which is Horizon Conference Management and Ekta ji and her team. Thank you and good night to all of you. And Dr. Aditya, you look dashing even at 9:33.
Just landed home, sir. Learning tips from the
Yeah,
best.
thank you so much. Thank you so much. But still, your energy levels are really high. Better than osimertinib.
Right. Thank you. Bye.